Good evening, everyone. I am Dr. Maunika, medical advisor from Shield Healthcare, and I all welcome delegates for today's topic, Challenges of a New Mother, Road Less Traveled, organized by Safe Motherhood Committee. I welcome you all for today's session, and I welcome Dr. Nitya ma'am. She's an MOC, consultant, MMM Hospital, and I hand over the session to you, ma'am.
Thank you. A very good evening to one and all. I'm extremely happy to greet everyone to this month's webinar of Oxy Safe Motherhood Committee. Being a new mother is not just a phase, but it's a transition. While it is empowering to become a mother, it brings with it its own challenges. A mother continues to labor long after the baby is born. Beyond the baby, caring for a new mother is as important, if not more than caring for her during pregnancy and delivery. So today's webinar is going to be an extensive discussion on the various challenges of a new mother, the road less traveled. It has been a tradition to start our programs with a Tamil Thai Vartha, followed by virtual lighting of the lamp. May the light dispel darkness and be a beacon of hope and prosperity. We shall now have the welcome address by Dr. Jayarani Kamaraj ma'am, who is the president of Oxy, a senior consultant in reproductive medicine at Akash Fertility Center. Ma'am has numerous awards in her kitty. Over to you, ma'am.
Thank you, Nitya. Anevarukkum Malay Vanakkam. A very happy evening wishes to one and all. It gives me great pleasure and honor to welcome you all for this wonderful webinar on a very, very important aspect of a mother, a postnatal mother, as rightly pointed out by my Safe Motherhood Committee chairperson, Dr. Rajshri. Road which is less traveled, that's what, but it is nice that we all should travel this road with a very happiness and very comfortable way, because this is a time that most of the women go through a lot of stress, as pointed out by Nitya. So to tackle on these issues, our committee has made a very nice, wonderful plan of very practical approach to the mother from the point of very many things like her health, the breastfeeding myths, misconceptions about the practical issues, and also about the psychological basis, and very importantly, the nutrition, which is very importantly, which is less, taken care during this period. For this, I think I should appreciate Rajshri for getting the joints to speak on a very practical issues, what we look into both as a consultant as well as a women close to attached to the mother, which is very importantly has to be taken into account. And I have the great privilege to welcome Dr. Charmila, who is a senior person who is well known for her practical approach to the practice point oriented talk. So she's the right person who will be talking on a very important aspect of a guide to the breastfeeding. We welcome you, Charmila, on behalf of Oxy 23. We welcome you for this wonderful webinar, and a very special welcome to Dr. Suresh Kumar, who will be talking on the psychological aspects. And sir is well known for his practical approach. We welcome you, sir. And a very special welcome to Dr. Shilpa, who is well known for her interesting talk on the nutrition and how to take care of a woman in the postnatal period to give her a good health, both for the baby as well as the mother, and to get her back to her normal shape and her fitness, which is well known to you. I welcome you, Dr. Shilpa, for this webinar. A very special welcome to our senior physicians here, Dr. Shanti Gunasingh Madam, Dr. Dhanlakshmi Madam, and all the senior delegates, and my special Oxy 23 team, and all the delegates here who have logged in. We welcome you all on behalf of Oxy 23 team. A very special welcome and thanks to Sheel for giving us this platform, and very special to Maunika and Shahiti for making this a very smooth and soft way. And once again, I welcome you all, and over to this nice webinar. Over to Nithya.
Thank you, ma'am. Upholding the tradition of praying to the Almighty to mightily bless us, we shall have the Oxy prayer by Dr. Kundavi Shankar ma'am. She's a secretary of Oxy, senior consultant of reproductive medicine at IRN MMM, also heading a successful fellowship program. Over to you, ma'am.
Thank you, Nithya. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Thank you, ma'am. We often talk about common postpartum complications like postpartum hemorrhage, anemia, and infection, and keep a watchful eye for complicated pregnancies. But we do take a physical and emotional struggles of a new mother lightly. We will begin our scientific session with a talk on comprehensive guide to breastfeeding by Dr. Charmila Ayyavoma. She is the Vice President-elect for Oxy 2024 and Chairperson of Clinical Research Committee of Oxy, a member and coordinator of numerous prestigious societies. Over to you, ma'am.
Thank you, Dr. Nithya, for that kind introduction. I would like to thank the President, Dr. Jayarani, for the opportunity, and the coordinator, Dr. Rajeshri, who took such great pains to make sure the program goes on. And when Dr. Jayarani, ma'am, when she gave the talk, I thought it will be little easy to prepare, but when I started, I knew that it is one of the most difficult topics to prepare on, because we think we know about it, but when you get into the subject, it's not, you don't get much of evidence for most of what you think is right. So when you go for the evidence, it actually tells you otherwise. So let me share my presentation on comprehensive guide to breastfeeding. I hope it's comprehensive enough. Because I hope I've just done justice, because as I said, it's an extremely difficult topic to talk on, because when you want to talk to a new mother, it's very difficult to convince her, and for that you need some evidence to talk on. And UNICEF is the best organization to talk on breastfeeding, and they've said it's the best possible start in life. It's a very good source of nutrition. It will bolster the brain development of the baby. It is going to give lifelong benefits for the mother and the baby. It's going to contribute significantly to the sense of security of both the mother and the baby, and the bonding with the mother, which happens early in life. And what are the disadvantages of not breastfeeding? There's going to be a high risk of diarrhea and other infections. The baby is going to likely to suffer more from malnutrition. There's actually an increased risk of death in their infancy if the baby is not breastfed. So the recommendations by UNICEF in 2021 was you need to initiate breastfeeding very early, that is within 1 hour of birth of the child. It needs to be an exclusive breastfeeding for the first 6 months. You can introduce nutritionally adequate and safe complementary foods at 6 months, along with continued breastfeeding up to 2 years of age or beyond. And this is going to offer a powerful line of defense against infection and malnutrition, and it will boost the brain development in the child. But what is the reality is, the Center for Disease Control says, despite very strong recommendations by organizations throughout the world, only 1 in 4 mothers report breastfeeding exclusively through the first 6 months. Let's find out what are the problems in maintaining the exclusive breastfeeding, which is advocated by so many organizations. The first and foremost is the lack of knowledge, which can be from the health providers, it can be from the patient, it can be from the attenders. That basic lack of knowledge is contributing to the mother not exclusively breastfeeding a baby. The cultural practices in many regions and countries where they feed other food to the newborns, the poor quality of care which is available to the mother and the child are actually responsible for the lack of early breastfeeding initiation and continuation. And you have to remember that in the initial days after giving birth, many new mothers struggle to learn how to breastfeed. And that's why the health provider is extremely important. And what is the role of healthcare providers for providing the care which is needed for the mother to continuously breastfeed exclusively is, they should know about what is milk production before they talk to the patient. They need to know the signs of good attachment at the breast by the baby, the signs of effective milk transfer, and they need to know how to encourage and support women with common breastfeeding problems. And they need to have the appropriate resources for safe medications usages and the prescriptions which can be given during a breastfeeding period of the mother. And the topics which a health provider needs to discuss with the patient who wants to breastfeed and who needs to breastfeed is the supply and demand nature of breastfeeding. They need to discuss about responsive breastfeeding. They have to understand that there's an individual variation of feeding. They cannot compare themselves to their relatives and the neighbors, and they keep on comparing, like, she had so much and I don't have. That variation they have to understand. They have to understand the feeding positions which are needed for the proper positioning of the baby and the sucking of the baby, and how it helps for the baby to attach to the breast. And the signs of effective feeding that the mother needs to understand to know that the baby is getting enough milk, and it's not actually possible to overfeed a breastfed baby, which can happen with bottle feeding. According to the NICE guidelines of 2021, these are the things you need to assess for a breastfeeding mother. You need to ask the parents the concerns they have about the baby's feeding. And you need to ask how often and how long these feeds are. You have to ask regarding the rhythmic sucking and audible swallowing which the baby does during feeding. And they have to actually know whether the baby is content after the feed and that the baby is waking up for feeds. The baby's weight gain or weight loss should be looked for, and the number of wet and dirty nappies that the baby is soaking, and the condition of the woman's breast and nipples. All these need to be assessed by the health provider when they're providing the service. And suppose there are concerns when they're doing the assessment, the health provider needs to observe the feeds that the mother is giving the baby. They have to check for whether they are adjusting the positioning and attachment to the breast. They need to talk about express breast milk if there's a problem with direct breastfeeding. And sometimes they may need a referral to an additional support like a lactation consultant or peer support. And you need to assess what tongue type the baby is not feeding properly. And what is actually responsive feeding? It means feeding in response to the baby's cues, which the mother needs to identify. And it will recognize the feeds. We need to recognize that the feeds are not just for nutrition of the baby. It is also for the love, comfort, and reassurance which happens between the baby and the mother. And it also involves a mother responding to her own desire to feed for her comfort and convenience, which is very common in the postpartum period when women tend to go into periods of depression. And sometimes this will help her to tide over that crisis. And we have to tell that all breastfeeding women need vitamin D supplements, which is a guideline by the NICE guidelines of 2021. What are the common reasons for the cessation of early breastfeeding, which is advocated? Two common reasons which has been put forth in the American Journal of Maternal Child Nursing in 2019 was whatever the mother thought as an inadequate supply which is giving the baby, or the symptoms of pain or nipple pain make them stop giving breast milk early in the lactation period. And when there's a failure to sustain exclusive breastfeeding, and the common reasons which the mother gives for the supplementation with bottles which she give and the early termination of breastfeeding is that there's insufficient milk. Then if she complains of insufficient milk production, you have to check for her health and the neonatal health, to check for the baby's sucking reflexes, see whether the baby is properly latching on, and find out the feeding frequency of milk production. You have to first make an attempt to identify and correct all the causes of low milk production before trying a milk booster. And sometimes galactogogues are tried in many places for boosting the milk production. And the oral galactogogues, which are tried or pharmacological or can be natural, which was available in that part of the region. And the pharmacological galactogogues which have been tried are domperidone, metoclopramide, sulpuride, and thyrotropin releasing hormone. But when you see the Cochrane review of 2022, they've said very clearly, there's no evidence of any pharmacological galactagogue helping in the increase of the infant weight. And there's very low quality evidence of increase in milk volume, which happens with these drugs. The mothers can have minor complaints like tiredness, nausea, headache, and dry mouth, which is due to the drug, but there are no adverse effects reported in the infants. And what about the natural oral galactagogues which have been tried? Banana flower, fennel, fenugreek, ginger, exbut, levant, cotton, moringa, palm dates, pork knuckle, shatavari, silymarin, torbugan leaves, and whatever available. The subgroup analysis in this Cochrane review was like no intervention helped, and they either benefited some benefit or there was no difference at all when the galactagogues were given. And even whatever they showed as benefit, it was a very low quality evidence. And when they compared a galactagogue versus another galactagogue, no one galactagogue is better than the other for any outcome. So the other method which has been put up in Cochrane and so many studies is there's some techniques for improving the breast milk production. This was easy to remember, the BOM method, that is breast care, oxytocin massage, and the Marmot technique, which are all combined together. And supposedly it increases the breast milk production. That is the BOM method. B is for breast care or massage. The second is oxytocin massage. Third is nipple cleansing. Fourth is early and regular breastfeeding. And the fifth is Marmot techniques, or you milk and massage, and that supposedly increases the milk production. And in the Marmot technique, you make the baby suck for 10 minutes every day so that it gets used to sucking. And what is oxytocin massage? It's a stimulation of the mother's nipple through the baby's mouth or through the massage. And you can massage the back of the mother, and this will increase the oxytocin hormone. And when oxytocin is secreted during this massage, the mothers seem to feel calm and relaxed. And this can increase the affection towards the baby and stimulates the release of oxytocin, which can actually accelerate the release of breast milk. And the breast care which you provide in this technique will stimulate prolactin, and that will accelerate the breast milk production as well. These are all small studies, but it seems to work because they are not, there's no intervention as such. There's something called a Speos method for increasing breast milk production. That is stimulation of endorphin, oxytocin, and suggestive. That is, you keep on talking to the mother regarding your problems. You try to solve each one of them. And that mental peace which you provide sometimes actually helps in increasing the milk production and accelerates the release of breast milk. And that is supposedly because of the increased work of prolactin and oxytocin. That's a recent update from 2019. There was something called a Milky Way program, which was started, and it is actually app-based. And it consists of 3 antenatal face-to-face educational sessions on lactation. And there'll be 2 postnatal telephone consultations at 1 week and 4 months postpartum. And in this study in 2021, they claimed that it caused an increase in the mother going for exclusive breastfeeding in the first 6 months. And the next problem which a mother usually complains of is the pain around the nipples. And for that, you have to check whether she's properly positioning her baby at the breast. And that will actually avoid the situation. But if you identify cracks on the nipple, then the milk can be expressed and the baby can be fed by cup and a spoon or a paladai. And it has been seen that applying that breast milk on the nipples actually heals them instead of any drug. And in a few days, these sore and cracked nipples improve and successful breastfeeding can be done. And the other maternal problems and difficulties which these mothers face is a constantly crying baby, which they don't know whether the baby is satisfied and it's crying for anything else. And that is one problem which makes them go for other methods of feeding other than breast milk. The other thing is they're worried about the maternal positioning. They're worried about whether they can express breast milk, and they don't know what is mastitis. And the other problem they face is the healthcare system and the social support, which needs to be from the partners, the fathers, and the family. And the sensation of dissatisfaction the mother has when she's not able to feed properly. and the very easy access to bottle feeding, which is making it easy for them to switch from breastfeeding to the other methods. What about crying baby? And for that, IAP 2021 said, you have to check whether the diaper is soiled before you think it's because the baby is not getting enough milk. And you should change it and then ensure that nothing else is bothering the baby, and then put the baby to the breast. If the baby is hungry, the baby is going to feed. And it needs to be fed as long as it's needed. It's not like the mother can decide how long she can feed. The baby has to decide that. And both the thin watery milk, which comes first, will be needed to quench the thirst of the baby. And the thicker and fat containing milk, which comes after, will satisfy the hunger. The baby continues to cry even after coming off one breast. It needs to be fed on the other. And what is the best position of feeding? It's whatever is comfortable to the mother is the best. There's nothing like a hard and fast rule, like this is the best and all that. And when awake, it's preferable to sit and feed the baby. But when she's lying down, when she's resting, she can actually lie down and feed, which we never used to advocate earlier. And how to use express breast milk, and it is like it can be done by hand expression, or any standard breast pump which is maintained with proper sterility can be used for expressing breast milk. They can be kept in a clean steel container for almost 4 to 6 hours at room temperature, and if they are refrigerated, they'd be kept around for 24 hours. And before feeding this express breast milk using a paladai or cup and spoon, the milk has to be brought to the room temperature by keeping the steel container in warm water. And suppose the milk is stored in a deep freezer, it can be thawed and consumed actually up to 3 months from the date of collection. And according to the CDC, it's not a biohazard keeping breast milk, and does not require any special handling. It is actually a food and can be stored alongside other foods in any refrigerator that is appropriate for food storage. But hands must be washed before preparing breast milk to avoid any contamination. And when should they suspect mastitis? Any worsening, reddening, and swelling of the breast which is persisting for more than 24 hours, despite self-management, it indicates mastitis and it needs care. And the other factors which contribute to an early cessation of breastfeeding is the absence of support in the workplace, which happens for working mothers. The advertisements which are put for formula feeds is another factor which actually moves them towards stopping breastfeeding, and the mothers perceive difficulties in breastfeeding. And what are the mother's difficulties in breastfeeding? We have to remember, for the majority, it is not easy and natural. They tend to look at movies and storybooks and they think it's very easy and natural, and the baby latches on and starts feeding. It is actually very painful in a majority of women, and it becomes a very difficult and challenging experience. And many times it's also related to a feeling of guilt from the mother that she's not able to feed properly, and the attenders add on to that guilt. And it also adds to a diminishing identity as a mother, which should not happen, and that should actually be taken care of by the support system which is there in the hospital and at home. And maternal breastfeeding satisfaction is defined as a perception by the mothers of personal satisfaction and success in breastfeeding. There were many studies which said the factors which is related to this feeling of satisfaction depends on the age of the mother. The younger mothers do not feel that satisfaction. The education of the mother matters, the employment of the mother matters, the household income, the parity of the mother, and the delivery type. Vaginal or cesarean delivery seems to matter in many patients. But knowledge, attitude, self-efficacy, intention, and social support when the mother receives will all affect satisfaction. There was an Australian study on maternal satisfaction where they said a higher household income in the family, a better educated partner, and a partner who's employed seem to improve breastfeeding practices. It actually worsens if the mother is also unemployed. Suppose there's a problem in the family regarding finances, it contributes to the mother not feeling satisfied. But there was no association between delivery type and breastfeeding, because the mothers in Australia who underwent a cesarean section actually tended to breastfeed longer when compared to a mother who had a vaginal delivery. And what about bottle feeding? Suppose the parents opt for bottle feeding, the health worker should have a one-to-one discussion about the safeness of formula feeding. They have to provide face-to-face support, and they have to provide written, digital, or telephonic information to the supplement. But it should not supplement the face-to-face support, and that's the NICE guidelines of 2021. And there's something called responsive bottle feeding, like responsive breastfeeding. It involves holding the baby close, pacing the feeds that the baby is fed with, and should avoid forcing the baby to finish the feed just because it is being prepared in the bottle. And they need to recognize the signs that the baby has got enough milk, because in bottle feeding, you can overfeed if you don't know these cues. And there's something which is dangerous in bottle feeding, and that is prop feeding. That is when the baby's feeding bottle is propped against a pillow or other support, rather than the baby and the bottle being held by the provider. That is a dangerous thing, because it can increase the risk of choking, aspiration, suffocation, teeth decay, and ear infections. So I'd like to summarize this talk by saying that supportive surroundings and expert instructions are mandatory for exclusive breastfeeding practices. You cannot think that you can just talk regarding a delivery part, and once that is over, that everything is over. You need to provide the support from your side. The support from the father is also very crucial, and all health facilities must be equipped to support breastfeeding and provide the optimal care to mothers and newborns. Breastfeeding may not always be easy for all the mothers, but it's always worth it. Thank you so much, Oxy and Jairani Madam, for the opportunity. Thank you so much. I think I finished on time, right?
Yes, ma'am. Thank you.
Yeah.
Nithya?
Yes, ma'am. Yeah. Thank you so much, ma'am. I'm sure everybody who's listened to the talk has no more doubts about breastfeeding. Next up, we have Ms. Shilpa Joshi, a consultant dietitian from Mumbai Diet and Health Center, course director at National Diabetes Educators Program. She was awarded this 3 award by FOGSI in 2019. Over to you, ma'am.
Thank you so much. And just give me a minute to share slides. I hope you can see my slides.
Yes, ma'am.
Yeah. So good afternoon, everybody. And thank you so much for inviting me here among this August audience. And I'm going to be talking about very simple nutrition topic, which is getting back into shape, overcoming challenges. So I'm going to be listing down a few challenges, and I'm going to be giving you simple tips about how one can overcome these challenges. Like my ma'am spoke before me, and she said that even, we think about these challenges being simple, like breastfeeding, but actually it's much more than what you see. And, increasingly we find that young women come to us postpartum and they say that, and if I could say that Princess Kate Middleton, after she delivered the baby, she had absolutely flat stomach. And how do you get that, when you are just coming out of the nursing home after postpartum, you have to look, like she looked, and it is really a very difficult task for us to tell them. So, so these are a little bit of scientific data before I go back to basic understanding. So these are predictors of postpartum weight retention. There are many things. So lifestyle behavior, socio-demographic behavior, psychological factors, they can all contribute to postpartum weight retention. Socio-demographic factors, which can be maternal age under 20 or over 40, primiparity, ethnicity. So this is an American paper again, and therefore they are talking about Africans, unemployment, and low income and low education level. Smoking cessation during pregnancy or early postpartum is also associated with long-term weight gain. So smoking cessation in general is associated with weight gain. Look at behavior patterns, and this is again coming from data, and then I'm going to be showing you from research to real world how things are changing. So the first thing is diet quality. So diet quality was reported to be higher in the first postpartum year compared to subsequent years, indicating that there is a decline in diet quality continues even after first year of postpartum. And the reason being that the woman is so busy caring for the child that she really does not have time to sort of look after her own need. Less adherence to healthier diet patterns. Specifically, we see that even in India, there is decreased fruit and vegetable intake and increased intake of energy-dense and nutrient-poor food during transition from pregnancy to postpartum. So sort of, women are behaving themselves very, very well during pregnancy because they know what they eat is going to impact the child. They also continue doing that till they are exclusively breastfeeding the child. And once the child starts to be weaned and the breastfeeding drops, they sort of, change their eating patterns and then they start opting for food which is less nutrient dense. Worsening of lifestyle behaviors in postpartum period could be due to demands associated with caring for the child. So which are the behavior patterns? The main and the most important behavior pattern which we have to understand is irregular sleep and meal timing. So when the child is sleeping, the mother is sleeping if she is not working. If she is working, then, a lot of times she has to go back to work, maybe after 6 months, but then she doesn't get enough sleep. So this is a big problem. Physical activity levels are generally inadequate in postpartum women. Sedentary behaviors may also be associated with postpartum weight retention. Psychological factors such as depression, anxiety are also predictors of postpartum weight retention. And effects of breastfeeding on postpartum weight. There is an inconsistency in literature on association of breastfeeding with postpartum weight. A woman continues to breastfeed, there'll be less weight gain, but there are other studies showing that that is not true, and that women tend to gain weight even if they breastfeed the infant. So now, what are the key findings? If you look at the literature, what are the key findings of efficacy of lifestyle intervention on postpartum women? So lifestyle intervention combining diet and physical activity components are efficacious for postpartum weight loss. In fact, that's the only thing that one can do in postpartum weight loss. We know that there are very, very few drugs available for weight loss in general, and most of them you wouldn't give it in postpartum period if the woman is I will eat what I want does not work. So even though you are running on a treadmill or you are doing what you have to do, one has to understand that one needs to watch out for what they are eating if they want to achieve a postpartum weight loss. So efficacious postpartum intervention should include ideally both diet and physical activity components, and to be delivered by health professionals. So we highly encourage women, telling them that just don't go on Google and find a diet plan, because what happens is this diet plan then does not support breastfeeding. So it is very important that the intensity, duration, length, etc., everything is spoken about. More research is required to determine optimal timing for initiation of postpartum lifestyle intervention. So a lot of times women come to us, 2 months after delivering, and they ask that, can we go on a weight loss now? Or should we wait till we stop exclusively breastfeeding the infant? Once the infant starts weaning, is that the correct time? And I personally believe you can get to eating right as soon as you want. You can. And then later on, whether you want to, if you're talking about portion control or decreasing calories, that can happen as the baby starts weaning. But there is no better time to start eating early. Start eating better as early as possible is a great idea. Total number of behavior change techniques include goal setting and self-monitoring behavior. And I think this is very, very important. You cannot, your goals have to be realistic, but one has to self-monitor their behavior. So they can't say that, the child was crying whole night and I was up the whole night. And then when child slept, I was so tired that I ate a bar of chocolate. I was so done, nursing the child that, I did something else. So one needs to sort of look after their emotional health, but at the same time, they need to self-monitor their behavior with greater reduction in energy intake and improving physical activity. I think that is something that is a self-monitoring behavior, which is important. Now, how would you intervene? So ideally, intervention settings in case of women who are postpartum, the best one are home-based intervention. Now, we have online consultations. There are so many apps which are available which help you to monitor your diet, because for a woman, it becomes very, very difficult to go out with a baby to a dietitian visit or to another healthcare professional visit. Also, there are also a lot of e-health technologies which are perceived as positive, user-friendly, and acceptable delivery medium, especially in postpartum weight loss. So it's very, very important that woman is comfortable when all these suggestions are made. If she's, there is a child with her, the child is crying, she's in a clinic setting, and she's actually not hearing what is being told to her. Now, this was research. All that I discussed with you is coming from the papers which are published. But from there, we come into real world, right? And real world are India specific challenges. And the biggest challenge, I think, in India is what is fed to the woman postpartum. And I get a lot of young women saying that, our mothers and mother-in-laws make it their life's mission to feed us and overfeed us. And there is very little that we have to say in that. And that is, I think, something. So high calorie, high fat, sugar laden foods, especially in this part of country. And I'm very sure also in the northern part of the country, where foods like laddus and halwas and all of this are given to women because they are exclusively breastfeeding. In fact, there is very minimal emphasis on fresh fruit, vegetable, and proteins in the diet. Galactogogues, which are given, okay, they are processed to become high calorie by adding sugar and ghee. So madam was talking about shatavari. Now, I remember when I was postpartum, shatavari was available only with sugar. So you couldn't get shatavari powder without sugar. Now, of course, it is available, but these kind of, if there are garden cress to be given, then garden cress is made into laddus with a lot of jaggery and lot of ghee and lot of coconut, and then it is given. So ghee is considered as a magic potion, and a lot of it is consumed, and exercise is very minimal. Lot of times they are not permitted to exercise, but a lot of times there are a lot of challenges wherein they are not allowed to go out and exercise at all. Now, food knowledge or understanding is important. So it's very important that protein-laden foods are eaten. Okay, so now hence on, all the slides are very, very practical. So, and there is a lot, I think, there are a lot of old wife tales associated that don't eat eggs, they are garam, and don't eat something because the child may get cold, and so on and so forth. So it's very important to include a proteinaceous breakfast. If they are happy to eat eggs, it's great, but then there are parathas, and there are uttapam, and there are doklas, and there is thalipeeth, and there are other foods which are good protein-laden foods which can be consumed by this women. Other thing which happens when protein-laden foods are eaten is satiety is achieved. Otherwise, women who breastfeed do not feel satiated after eating any food. They're perpetually hungry, and these foods actually are magic portion, and therefore they help you to control your portion size. And once that is done, at least weight gain is stalled. We do not require weight loss at that point, but we do not want the woman to further gain weight. So similarly, these are snacking options, whether it's milk, it's buttermilk. For somebody who's lactose intolerant, there are nut milks, plant-based milks, which are available. There are nuts, there are seeds. Also, seeds are excellent galactogogues in case, especially if the woman is in postpartum period still breastfeeding. And it's very, very important that they eat enough square meals. So it's very, very important that they eat vegetables, they eat salads, they eat good amount of proteins, whether coming from dal, yogurt, if they are vegetarian. If they are not vegetarian, they can include non-vegetarian foods at that point. It's very, very important that they eat all aspects of meal. So a lot of time what is seen is that they crave for eating something fun, and in that bargain, they stop eating regular balanced meals in the postpartum period, which leads to weight gain rather than weight maintenance. So these are some practical tips. Again, like, if a lot of women do not like to eat proteins, especially dal, so they might just eat rice, or they might eat vegetable and rice. So it's very important that you add dal to it so that you achieve a lower glycemic index of food and thereby stop weight gain and later on achieve weight loss. Then fruit, instead of just eating fruits, it's very important to add nuts. It also improves the quality of breast milk, but it also aids in weight loss in postpartum period. It's very important to add fiber to achieve satiety in the food, and therefore instead of just having chapatis with a lot of greens in it can help, to achieve tackle that fiber deficit which is there. This is poha. Again, just eating poha, adding proteins to it, adding organic acids to it will help you to sort of stall weight gain. So eating yogurt or paneer or other things with it will help to stall weight gain. Instead of drinking, these, I know people don't drink Coke stuff and other things in the postpartum period, but they definitely drink a lot of milkshakes in postpartum period. And instead of that, maybe a buttermilk, maybe soy milk or some vegan protein shake. If none of this suits them, it's very, very important. So it's very important to choose a right kind of drink. It's very hot now. So, one is thirsty all the time, and this is what one can choose. Now, it's very, very important that this is followed when food is eaten. So this is called as plate partitioning method. And in plate partitioning method, what is very important, that ample amount of vegetables are eaten. This is something which is lacking among Indians. So if it is, even a vegetarian Indian does not eat enough vegetables. So they will eat enough cereals, but they will not eat enough vegetables. Thereby, they have something called as hidden hunger. Hidden hunger is hunger of minerals and vitamins. So we advise them to eat raw and cooked vegetables, a portion of protein, which is about 1/4 of the plate, and just a 1/4 of plate of carbohydrates. This helps in weight maintenance, postpartum, and weight loss later on. So whether it is vegetarian food or it is non-vegetarian food. So a lot of times when non-vegetarian food is eaten, people feel that now that I'm eating non-veg, I don't need to eat vegetarian food. And that does not work. Even then, a lot of vegetarian food is necessary because it gives a lot of satiety to the woman who is eating it. So like I said, half a plate of salad, 2 proteins and 1 carbohydrate is a great idea to, initiate weight loss or even initiate weight maintenance. So again, the same thing, idli sambar, lot of sambar with idli, it will help you. The same meal will help you to lose weight rather than gain weight. Order of eating is very, very important. So there is enough and more research done on how one should eat food. And ordered eating, actually, it's done by an Indian lady called as Alpana Shukla in Jocelyn. And she has shown that the way you eat food helps you to lose weight. So if you begin with protein and then fiber, and at the end choose a carbohydrate, it doesn't matter what you choose, whether you choose roti or you choose rice or you choose millets, whatever it is, if you choose it at the end of the meal, the weight gain is much lesser. Weight loss is much faster with same amount of food because you are not able to eat that carbohydrate portion that you were supposed to eat. So these are few mid-meal options. So instead of eating biscuits, it's far better to eat a chapati with a lot of greens put in it. This is a laddu, methi laddu, which is very frequently eaten in postpartum period with a milkshake. It's much better to eat nuts, maybe just methi, which is soaked in water or is added to buttermilk along with it. You save on a lot of calories, but at the same time, you get goodness of whatever this meal was going to give you. So instead of having rolls and nimbu pani, which is higher in calories, one can have a fruit and maybe soy milk or maybe just regular milk. Or as compared to that, one can have sprouts or one can have eggs, which gives you even lower calories, but much greater nutrition. So it's very important that postpartum period, post 6 months, once the exclusive breastfeeding stops and a lot of weight loss wants to be done at that point, or one has to initiate, meal replacements can be taken. It's very important that a lot of vegetables are eaten because they really help you in weight loss, but just don't restrict to palak and methi. Eat a lot of greens. They will really aid in weight loss. And low calorie food options like fruit. Okay, these are various kinds of fruits which are low in calorie, which will actually aid in weight loss. I know this is a season of mangoes and lychees and jackfruit, which is all high glycemic index, high calorie. But if you have, so this jamun is available right now in summer, this one. Yeah, and one can have this, and this is really low in calorie. It is also seasonal, it is also regional, and that's like great food option, full of vitamins and minerals for you and the baby. So it's very easy if you choose such fruits to lose weight. A lot of people tend to eat desserts because they say that, oh, it's prasad, and therefore we need to eat that laddu or that whatever is eaten. So, one needs to change attitude. Then you also in prasad, you can have fruits rather than having mithai. So 5 keys to sustain weight losses, it has to be specific, it has to be measurable, achievable, relevant, and timely. It has to include an exercise and an eating plan. One needs to track progress. So one needs to stand on weighing scale or go measure yourself very regularly. Incorporate others in the meal plan. So whether mother, mother-in-law, husband, everybody has to be part of it. Prioritize your mental health. If it's bothering you, talk about it, because do not use food as a shoulder that you cry on. A lot of people, when they get upset, instead of talking to people, they just tend to eat more, and that is something which is a problem. And keep the momentum going. And it is very, very important, especially in the postpartum period, to keep reevaluating your eating plan. So what are these? Specific means what exactly do I do? If I want to lose weight, what is it that I need to do? Measurable. How do I track my progress? If, how do I know I have lost weight? Whether I should weigh myself, I should measure myself, what should I do? Attainable. Is it realistically possible for me? If you're looking at losing 20 kgs in first 1 year, it is not going to be realistically possible. So find that realistic goal. Relevant, why am I doing this? And time oriented, when will I have this completed? So don't keep it open-ended. Give yourself that by the time, the baby is 1 year old, I want to fit into whatever. On baby's first birthday, I want to fit into the dress which I wore before I got pregnant, or whatever it is that the woman needs to do. So it is very important to create awareness of unhealthy eating habits, create a competing, more healthy response for unhealthy eating habits. So if a woman sort of gets disturbed when baby cries, and she tends to, help herself with a dessert or help herself with fried food, it's very important that these things are not bought in the house so that she doesn't eat them. Work on motivation, compliance for developing habit. Teach relaxation techniques for difficult moments. I think this is very, very important, whether postpartum or any kind of weight loss. Most of the weight loss behaviors stop when there is a lot of stress around. And I think relaxation, and that is why yoga has shown such dramatic results with weight loss, because pranayam actually relaxes you. So even if you don't know pranayam, whenever one is stressed, it's very important to breathe in, breathe out, give it a minute, and after that, make a decision whether you want to eat or not eat, and generalize these skills and habits to all areas of life. Thank you. So, and this is the last one, monitoring systems. So keep a check on sleep. I know with, when baby is small, it's very difficult to get a full night's sleep, but it's very important to sleep. Keep a check on the caloric intake, regular monitoring of your blood sugar levels, if at all they are relevant, especially in women who have GDM or who have who had pre-gestational diabetes. Keep check on the exercise routine. So it's very important to get some kind of exercise and keep a check on it and monitor the progress by checking weight on a fixed day every week. So these are some basic tips, and I'll be very happy to answer any question if you have. Thank you so much for the invitation.
Thank you so much, ma'am. I'm sure not just the postnatal mothers, we have also learned a lot of things about diet and nutrition from your presentation, and thank you so much. Moving on to the next important aspect of postpartum recovery, the emotional roller coaster and how to handle, by Dr. Suresh Kumar sir. Sir is currently the head of research and development, City Rise, a global platform for mental health. He has worked for several international and UN organizations. He has assisted substance abuse disorder prevention and treatment interventions in several countries, such as Afghanistan, Bangladesh, Bhutan, China, Iran, Malaysia, Maldives, Mauritius, Myanmar, Sri Lanka, Vietnam, Thailand, Nepal, and very many. Over to you, sir. So you're muted. So unmute yourselves. Sir, we're not able to hear you, sir.
So you have to unmute yourself, sir.
Unmute yourself, sir.
Sahiti,
Yes, ma'am.
Yeah.
Yeah, I have requested sir to unmute.
Yeah.
Yes.
Can I?
Yes,
Is
sir.
the
Yes,
slides
sir.
visible? Is the slides
Yes, sir.
visible?
Yes,
Okay.
sir.
Thank you, Dr. Nitya. First of all, many thanks to OGSSI for the invitation. My special thanks to Dr. Shanti for the personal invitation. It's a pleasure to be here and listening to eminent speakers. What I'll be talking about is a slightly different topic, which has been a little bit touched upon by the previous speaker. We talk about the emotional roller coaster that Dr. Rajeshri described as, for this topic. And I think to begin with, for the first-time mother, even while she's pregnant, there are certain issues. Pregnancy is a state of joy. That's what we generally believe. It leads to exaltation. But unfortunately, for some, pregnancy is a very stressful life event. It's listed as the 12th most stressful life event in the adults. And in pregnancy, women, first-time women in particular, tend to lose the autonomy that they have, particularly with their partners. There is also this fear of losing one's own identity because there is a need to change your own identity. Also, there is a need to change your own lifestyle. These could be very stressful for pregnant women. Those who are very worried about their body image, I think all women are beautiful, but some women tend to think their beauty only lies in the body and the body image. And those are the people who are going to be very much affected by pregnancy because they are growing bigger and then they don't want to show up in a professional way. And I think they feel that they are not competent to go and work in a setting. Sometimes new tasks are assigned by the family members and the culture for a pregnant woman. And so becoming a mother can also be perceived as a stress for the first-time women in particular. So we tend to use a very general term called postpartum distress because most of the psychological problems occur postpartum. And largely it may be due to hormonal changes and variety of things. It is multifactorial. But when you talk about postpartum distress that is occurring for the first time in a mother who become like a mother for a newborn baby, there are a variety of things that happen. There are some very common things like baby blues, to the individual having a self-doubt and guilt about whether she's capable of being a mother, whether she's capable of looking after a mother and mothering an infant very well, and then going through this body image disturbances, are going through a relationship strain with their partners and other people in the family. These 4 issues, which are in blue, generally do not require any specific mental health attention. Often obstetricians and gynecologists can easily deal with this by providing them understanding and support. But there are other issues which could become a concern for the first-time mother and perhaps sometimes require a professional assistance from someone else. Examples of that would be adjustment problems, attachment problems, anxiety and worry, depression, particularly the postpartum depression, which is very, very important and relevant, and a very rare condition called postpartum psychosis that could be very intimidating. Now, generally, you want to look at sometimes what are the factors that contribute to this elevated levels of postpartum distress in first-time mothers. First, you look at some of the risk factors. Sleep is very vital for everybody. We all know that adequate sleep hygiene, and if persons do not have an adequate sleep hygiene, they have a circadian rhythm disturbance. This is very predictive of depressive symptoms later on for any adult. That's why we worry these days about younger children spending so much of a time in social media, not sleeping adequately. It's almost like a predictor for future depression. So postnatally, many women are not able to sleep and they are deprived of sleep because they're constantly looking after the infant who doesn't sleep very well in the night. And that postnatal depression itself, sleep deprivation itself, could be a risk factor for postpartum distress. Loneliness is a very important feeling. Despite being part of the family, despite being other people, some women feel very lonely and isolated. And I think the sense of isolation and loneliness is also very predictive. Some women can go through fear and distress and they won't trust anybody, their child. They are very worried about how other people will be handling their children. They won't want to trust the mother to do this. and not the partner to do this work, the fear and distress could be a very important factor. Also, birthing in a very medicalized system can also be a risk factor. That's why in many places, they are encouraging community births, and then, there are places where it's culturally very similar to them, not in a very super specialized medicalized setting. And also, the feelings of parental unworthiness is a very important factor, risk factor. And people have to be feeling the power of empowerment. That's exactly one first-time mothers have to feel, but not all women feel empowered and they feel disempowered. That could be a risk factor. Often, if somebody is going to be, happening, this birth is going to be happening in a different culture, where different language is spoken, that could also be an important factor. And some of the people don't expect the infant. For some reasons, they're angry towards the infant for whatever reasons. And that could also be a predictor. And social oppression, unfortunately, still is a risk factor for postpartum distress in general. But having said about the risk factors, it's equally important to talk about the protective factors, because the support from the family, peer, and social support is very critical. Offering individualized home care is extremely important, because that's why I think in India, many people don't go through this postpartum distress as well as they go to in the West, because you think the individualized home care that the girl gets at her home in the mother's place is very special. And I think the prenatal attachment, how the mother connects to the child when she's actually being pregnant, is also a very important protective factor. Mothers who are attached to their infant when they are growing up, communicate with the mother, with the infant, even as a pregnant woman. Those are the prenatal attachments that will be a protective factor. And I think healthcare providers having an open dialogue about postpartum period and the various stressors related to that and providing guidance for that is also very protective. And so reassuring compassionate healthcare professionals, the obstetricians play a very good important role in providing that kind of a compassionate care to them. And preparing for the childbirth and care is almost like having a roadmap for having a better delivery. And I think whenever anything happens, early intervention is also very protective. So you talk about baby blue syndrome, which is a very simple thing. It has almost all the very minor symptoms of depression, like mood swings, crying, difficulty sleeping, not able to eat, unable to concentrate. But these things usually peak within 3 to 5 days after the birth. And mostly they are caused by fluctuations in the hormones and rapid change in the hormones that happens after the childbirth. It usually goes away within a few days. And I think most of the time, obstetricians and gynecologists actually look after that. We never happen to see as mental health professionals. Interventions are usually understanding, support, help with learning how to care for the baby. If only the symptoms persist for 2 weeks, you begin to think whether it be a harbinger for a later on postpartum depression. The other common problem that you very often see is adjustment problem. People are finding it very difficult to adjust to the change brought about by the birth of a newborn. There is an additional person, and that requires a lot of adjustment in the life of a person. And that could be a very distressing experience that may require support, guidance, mostly at the family level, and also sometimes guidance from a psychologist may be very helpful. I think attachment problems are important because you expect every mother to be instantly attached to the infant. We think it's instinctual. One has to connect with the child, but unfortunately, not all mothers connect straight away, and they have a bit of a difficulties. And they also bond again with proper rest and proper support. But if the bonding difficulties continue, I think this definitely requires to be explored. Anxiety is extremely prevalent. About 10 to 15% of the first-time mothers would experience anxiety. The anxiety is dominantly characterized by fear and expecting something danger to happen, constantly worrying about the child, always worrying that some germs will catch the child. I have to keep this diaper changing. I am really wanting to keep the room clean. They're very obsessed about it. And they're excessively concerned about the newborn baby. And they are the ones who are reaching out to the pediatrician in the middle of the night 5 times, and even after repeated reassurance. And they are very vigilant. And then their muscles are very tense and they complain of headaches and they are unable to relax. And they actually avoid certain things. And avoidant behavior is very characteristic of anxiety. Often anxiety and depression are twins. They coexist together. The simple intervention for anxiety is what Shilpa Joshi was talking about, exercise. What is good for the body is also good for the mind. If physical activity is going to improve your physical health, and we know that it improves several things from weight loss to cardiovascular problems and to cerebrovascular problems. I think exercise is also the remedy for mental health too. So exercise is the number one evidence-based treatment for anxiety. And then relaxation. The relaxation could be done by a simple muscle relaxation exercise called Jacobson relaxation exercise, or through deep breathing that Shilpa was talking about. And I think either methods you can achieve this relaxation. Or sometimes people could have a talk therapy with a psychiatrist or a psychologist for a psychological intervention. Depression is again very common, both during pregnancy. About 10% of women go through depression in pregnancy, and 10 to 15% experience postnatal or postpartum depression. Very much the symptoms are not different. They're same, whether it happens during pregnancy or postpartum. But each individual has a very unique experience of depression. You can't compare two people's depression and carry on notes, because I think they're entirely different, because the journey is very unique. So if you look at postpartum depression in particular, what are the symptoms? The symptoms are either emotional or sleep, or related to some somatic symptoms or cognitive symptoms. The typical emotional symptoms are crying, sadness, lack of pleasure, negative attitudes, sometimes irritability. Easy to pick up. Ask the people how they feel. Sleep is very important. They are sleep deprived. Not only sleep deprived, the sleep quality is affected. I think the quality of sleep, which is when you sleep, the sleep rhythm getting affected, is pretty important. The bodily symptoms are also important, because anorexia, gastrointestinal symptoms, ringing in the ear, these are very common symptoms in depression. They often present to the physician with these physical symptoms, not with emotional and other symptoms. Sleep and somatic symptoms are tokens of entry to a physician and to complain about their depression. And cognitive symptoms are, they just have no attention, they're not able to plan well and execute things. So there are very risk factors for it, slightly different from the risk factors we saw earlier on for general distress. Specifically for postpartum depression, there are certain risk factors. The risk factors are, if a woman has already gone through a history of depression, she's most likely to go through a postpartum depression. If the lady has experienced premenstrual syndrome, very, very specifically, I think that also is a predictor of postpartum depression. I think having a negative attitude towards a baby and reluctance to accept the gender of the baby, it's unfortunate that the women are still, some of the women are still very reluctant to accept a particular gender, and which is very shameful. But I think that can also contribute to postpartum depression. And a history of sexual abuse is a predictor for many of the mental health problems, including postpartum depression. Obstetric risk factors are also very important, because it's extremely important to prevent these obstetric risk factors as far as possible. These are modifiable risk factors or malleable risk factors. Risky pregnancy, emergency cesarean operation, for example, cesarean section, for example, or multiple hospitalizations during pregnancy. These are important things. The pregnancy has been very risky. I think the risk factors for PPD is very high. The passage of meconium, umbilical cord prolapse, preterm or low birth infant, or low hemoglobin or other factors. So these are important risk factors for postpartum depression. There are also social factors for postpartum depression. Those who have experienced domestic violence, but I think in this country, still domestic violence is a reality, even among educated communities. Women are subjected to domestic violence by the spouses, sexually, physically, and verbally. And I think that's a very important predictive factor. And lack of social support. And smoking, unfortunately, it's becoming a very common thing, even among women. And I think smoking among women can also be an important factor for PPD. And I think the sleep cycle disturbance, the lack of physical activities, vitamin B6 deficiency could also contribute to PPD. So it's very important, because given that it's a very severe condition, given that it is negative consequences are too high, we need to detect it early and manage the depression quite effectively in order to make sure that the mother and the infant's health is protected. So we need to really detect it, manage it. If not able to manage by an obstetrician, I think refer it properly at a proper time. So screening and having an associated referral services in your own health system is pretty important. I think the days to come, we need to have collaborative care. We need to have multiple healthcare professionals working with the perinatal women. That includes obstetrician, pediatrician, sometimes psychologists and psychiatrists. This team is very important to work with the perinatal women in order to provide comprehensive healthcare. What can the obstetricians do? Simply ask 2 questions. And that will give you a clue whether the person is going through a postpartum depression. Just ask, during the past month or past 15 days, have you ever been bothered by having little interest in things that you are interested in, or pleasure in doing things have been completely lost? Have you lost interest in watching a television, in talking to your friends, seeing a movie? The second thing you ask is, during the last month, have you been bothered by feeling down, depressed, and hopeless? Have you felt low? Have you felt sad? Have you felt hopeless in the past month? If the person answers yes to any single question, that's a clue for you that you may be dealing with a postpartum depression in this first-time mother. How do you prevent? I'm not tired of saying again and again, increasing the physical activity, prescribing exercise is important. Psychological intervention sometimes could be very preventive in terms of offering support, but we don't know whether dietary supplements and pharmaceutical interventions are preventive in pharmaceutical depression, postpartum depression. But whereas the same thing that work in prevention will also work in treatment. For example, all the things Shilpa Joshi talked about in terms of exercise interventions, exercise and intervention should last at least for 12 to 24 weeks. So it should be something like, the prescription should be something like group walking, an individual walking, a whole body gentle stretching exercise, or an individualized exercise prescription based on the heart rate targeted. Yoga is not assuming awkward postures. Yoga is a way of life. You need to breathe deeply. And I think people who deep breathe regularly and steadily, and they can be overcoming this anxiety because you stay still in the current. The pendulum is not swinging backwards and forwards. Massages are becoming very popular. That's why I think so many spas are sprung up in Chennai so easily. These massage parlors, how much scientifically they offer, we don't know. But I think well done. Some of the Thai massages and other massages could be very helpful in relaxing the individual, not just the body, but also the mind. Acupuncture is also becoming very promising and a potential thing for intervening with anxiety and depression in particular. There are other psychological interventions that are very specific. They are evidence-based. The evidence-based therapies are cognitive behavioral therapy, interpersonal psychotherapy, and other supportive psychotherapy, which is like talk therapy, just offering support, guidance, and ventilation and a catharsis for a person who's going through so much. Another treatment strategies would include omega-3 fatty acids, because omega-3 fatty acids significantly improve depressive symptoms in perinatal women, particularly regardless of whether they are pregnant or postpartum. Most of the obstetricians are happy to prescribe omega-3 fatty acid rather than an antidepressant. I really think it's welcome. But we choose an omega-3 fatty acid, which has got a higher ratio of EPA versus DHA, which will be at least more than 1.5. But EPA is good as an antidepressant. DHA is more for cognitive abilities and cardiovascular things. And so I think you prefer EPA more than DHA in the ratio of more than 1.5 to have a significant impact as an antidepressant. The omega-3 fatty acids are preferred because they have a low incidence of side effects relative to antidepressants. So they may be the first choice in the future. The other pharmaceutical interventions are typically when you send it to a psychiatrist, you can be pretty sure he'll come back with the prescription without a doubt. And so sometimes it's very annoying to the obstetrician, but I think you need to live with us. I think we'll invariably prescribe an SSRI, something like a sertraline, which is very, very safe, escitalopram. And some people would respond to fluoxamine when they have a lot of obsessive symptoms. Other drugs like bupropion and venlafaxine is also evidence-based. But there is a new drug which has been recently approved by FDA called brexanolone, because brexanolone is a magic, because it rapidly works on postpartum depression and reverses depression very quickly, unlike the antidepressants, which take a long lag period. This is given as an injection, but unfortunately in this country, it's still not available. They're fighting very hard to get brexanolone in India. Once that comes, it'll be very easy to deal with postpartum depression. Then you won't be worrying about postpartum depressive mothers committing suicide are harming their children and becoming a long journey for them, which is very difficult for them to bear. So I think brexanolone will be a game changer in the treatment of PPD. That's the first antidepressant ever to be approved only for the treatment of postpartum depression, because it rapidly works on the changing hormonal levels after birth. So the postpartum psychosis is a rare condition. You will often recognize this and it's sent to a mental health professional. And this postpartum psychosis is perhaps the severest form of mental illness. It's characterized by paranoia, delusions, hallucinations, sometimes extremely difficult for the family to manage. They want to harm the child, they want to harm themselves. IMD identification is very important before you lose the person or the infant. So one has to rule out the organic causes when you deal with the postpartum psychosis. And once you rule out an organic cause, you typically treat them with atypical antipsychotic like olanzapine. Sometimes they would require a mood stabilizer. Okay. One of the last slides is about mother-infant bonding in a born baby with a newborn baby for the first-time mother. Usually the predictors where the mother, the first-time mother is not bonding with the infant is due to the fact that there is a depression going on. On the marital status is a non-union marital status. Or she is an employee of an organization which doesn't care about or support maternity and having a pregnancy complication. A non-breastfeeding person, as Dr. Sharmila was talking about, I think non-breastfeeding does not make the people to connect with the child so much. And substance use history and social support are the predictors, lack of social support are predictors. On the other hand, providing social support could be a protective factor in increasing the bonding. And I think we need to screen whenever somebody complains about bonding difficulties, you screen for postpartum depression and treat them. So I was wondering how to conclude when a topic like emotional roller coaster was given. And I thought I will end it with the poetry. I'm not a poet. I leaned on ChatGPT. These days, it takes only 2 seconds for the ChatGPT to provide poetry on anything. I typed in and said, first-time mothers, emotional problems. There comes a long poem. I just read the first and the last paragraph. In the realm of motherhood, emotions run deep. A beautiful journey, but sometimes not so sweet. For the first-time mothers, a mix of joy and fear, a roller coaster ride, shedding many a tear. So, dear first-time mother, hold your head up high. You are doing amazing. Even on days you might cry. Your emotions are valid. Your journey is unique. In this beautiful chaos, find the strength you seek. Thank you very much. I really love ChatGPT has stolen from Rajeshree's roller coaster. Thank you so much.
Nitya, have you unmuted? Thank you, sir.
Thank you, ma'am.
Thank you, sir. Nitya, unmute yourself. Nitya. Nitya.
Rashri, நீ continue பண்ணிரு.
Okay, thank you, sir. Thank you, sir. You've covered it beautifully, starting from the problems which we can deal on our own and what we need to do. And when do we refer to you? Thank you so much. It was precise and it was well covered, sir. Thank you so much, sir. Thank you, sir.
Thank you so much, sir. Sorry, there was a connection problem. Next, moving on to the next session. The most awaited session of any webinar is the panel.
Rajshri, it's so C3 senior persons. Any questions are there in the chat box?
No, ma'am. I asked Sagiti.
Okay, then fine.
Ma'am, I have a question for sir. Suppose
that's
early
what-
pregnancy, when a patient is very anxious. Today we had a doctor who's also a pediatrician, very anxious. She says, I can't manage this pregnancy. She's only about 7 weeks. Should we really be worried and screen for psychosis, and how do we go about it?
Oh, we don't really screen for psychosis because worrying is so common. And I think human beings worry a lot. Civilized sections worry a lot.
She started crying, sir, being a
No,
pediatrician.
I think you screen for depression.
Okay.
I think medical professionals are very notorious to develop emotional problems. We deal with a range of problems every day in life. But when we face problems, we succumb to it very easily because we can solve everybody's problems, but not our own. That's a problem, right? So I think we don't know the solutions for ourselves. I think you screen for anxiety and depression. Anxiety is common than depression. Anxiety is usually managed without medication. Depression sometimes require medication. That's the difference. And I think anxiety is characterized by fear and worrying. Depression is carried out by sadness and somatic symptoms and sleep disturbance. That sleep is a common thing between anxiety and depression. I think somatic symptoms and cognitive symptoms and emotional symptoms are very predominant in depression. So you can take the difference. It doesn't make a difference because treatment is the same for both. That's why psychiatrists are very funny. You send a person with anxiety, you get the same prescription. Send a person with depression, you get the same prescription. I think what the psychiatrists are doing. Our science is so funny at this point in time. SSRI is good for both anxiety and depression management. And exercise, yoga, relaxation helps in everything. I think we need to really screen for anxiety and depression rather than for psychosis. Psychosis is a rare condition. We don't have to think about it. I think going away from reality is not so easy.
So,
Should we follow any questionnaire for evaluating mental health in pregnancy, sir, when we have such doubts? Any questionnaire we have to take?
I told you the screening question called 2 questions. Is simply asked whether you have lost pleasure. Losing pleasure is a very important vital sign. You are not interested in things that you are usually interested in. That's a simple question. Second, ask about how do you feel. If you get one of this, I think you go for the next one. Next one is extremely commonly used one called patient health questionnaire, PHQ-9. PHQ-9 is an extremely sensitive questionnaire and also very specific questionnaire. It can easily pick up depression in a clinical setting. So I think PHQ can be administered by anybody. It's a self-administered question. You can download it from anybody, from the net, PHQ-9, and keep it in your clinic. Ask them to rate it. And so you can say whether the person is going through a mild depression, moderate depression, or a severe depression, just looking at the scores. And I think the clinician's opinion will be exactly the same. It's an extremely valuable instrument.
So
So
is
can
there
you make
any
it as a routine questionnaire to these women, pregnant women?
That's what I'm saying. You ask the 2 screening questions, and then when the one question is positive, you apply the 9-item questionnaire. That's the easiest way of picking up the PPD in a clinic. I think obstetrician should do that. It's done routinely in the Western setting, where I think in the perinatal clinics or, like in the mother-infant clinics, whatever they call, they do that regularly.
So in a postnatal mother, when is it the right time to, give them these questionnaire post?
No, don't answer the question to persons when something has lasted less than 2 weeks. I think 2 weeks is usually the time we give for any symptom, because we believe that symptoms will resolve by itself with some support, with some rest and some guidance within 2 weeks. If they last and persist beyond 2 weeks, that's when it's a matter of concern. That's where you up your screenings and questionnaires and all that. Straight away ask them to do all this. People become more anxious and depressed. Never send them to a psychiatrist. That will be the most depressing experience for them when they walk into the clinic and see so many depressed people over there. I'm not going to be here. And why did my obstetrician send me here? So I would rather say that, you manage it. I think you can very well manage it. It's not very difficult. And I think you should manage. In the first 2 weeks, things usually resolve. And I think when it goes beyond 2 weeks, when you really, administer a question, when it's a severe depression, you can't handle it. That's when you probably think that the person requires an antidepressant. You send. Till then, you can manage with support, relaxation, and send them for yoga, either omega-3 fatty acids. All that could be done very easily by you.
Thank you, sir.
Dr. Suresh, can I ask one question to you, Dr. Justin Paul here?
Yeah.
I was listening to your talk. You had talked about domestic violence in some of these pregnant women. I would like to know from you, from your experience, do you find certain type of pregnant women more prone for domestic violence? Or in other words, women with heart disease going through pregnancy. I have come across a lot of patients going through domestic violence. So having a heart disease, is it a risk factor for increasing domestic violence in pregnancy? Have you had such an experience?
No, I think, I would have a very different opinion about it. I know that there could be some associations. Associations can be picked up in any research studies. But I think in the real world, you look at the different strata of the society, you'll be surprised how prevalent domestic violence is. I used to believe that the domestic violence was prevalent only in the lower sections of the society, in those, like slum-dwelling women being subjected to serious domestic violence. At least that is what comes to notice of the people. The greatest predictor of domestic violence in southern India is alcohol use disorder by men. I think it's a singular reason why they are subjecting their women to domestic violence. There could be many more reasons. The saddest feeling is domestic violence is being normalized in many places and cultures. Even in the educated society, if the woman is beaten up, the first reaction of the family is, you don't have to talk about it. Your father did that to me, so why are you making a complaint about it? Your brother did it when you were growing up. So when you normalize such kind of abuse, this is a serious concern. I think it's a societal issue. No, we can keep on talking about the domestic violence, that will become a debate of itself. But I think domestic violence is extremely common. My unfortunate feeling is domestic violence predicts many things, particularly depression, also in pregnant women, postpartum depression.
Any woman with chronic disease, especially if she's a primary, and heart disease and all that comes under that. And we see that they undergo a lot of abuse too, because they have to be brought frequently to hospital, so much treatment and so much uncertainty over the outcome. So all that naturally adds up to the anxiety, and that is what generally we have seen.
I've seen a small study in 27 pregnant women with prosthetic heart valves. I am interested in women with the heart disease. I'm also interested in domestic violence as an issue as such. So I did this in this particular 27 women. All of them had some form of domestic, intimate partner violence. 50% of them had physical abuse, and almost all of them had verbal abuse, and separation and divorce were all there in these 27 women. But then I could not take it forward. This was not, I couldn't publish the data as such because we had not taken this input in our ethical committee presentation. So this data could not be published.
But all patients we have seen, epileptics, cardiac disease, then chronic renal disease, all these patients, they really find it very difficult in their. Nitya?
Yes, ma'am. Okay. Thank you, sir. Coming to the next session, which is the most awaited session of any webinar, is the panel discussion. Today's panel is put together and moderated by our dynamic chair of Safe Motherhood Committee, Dr. Rajeshri ma'am. She's going to take us through some of the health needs of a new mother and how to address them. Dr. Rajeshri ma'am is a consultant at Sri Swasthya Clinic and executive committee member of OXI. Our panelist for the day would be Dr. Shanti Gunasingh ma'am, who needs no further introduction. She is a former director of IOG, ISO KGH, and HOD of KMC, past president of OXI and Women Doctors Association, and an enthusiast of academic activities. Dr. Dhanalakshmi ma'am, a professor from Sri Ramachandra Institute of Higher Education and Research, another academic enthusiast. She's a UG and a post-graduation teacher, executive committee member of OXI, and chairperson of AICOG 2015. Next, Dr. Vijaya Lakshmi, who's the HOD of Infectious Diseases at Kaveri Hospital and SIMS. She is a recipient of Power Women Award in Infectious Disease in 2021 and a Mayor COVID Warrior Award in 2021. Dr. Justin Paul, sir, who is a professor and Institute of Cardiology at Madras Medical College. He has a keen interest and was a pioneer in developing interventional cardiology at Stanley and Women's Medical College, and is the STMI management program for Tamil Nadu government. We welcome all the panelists today. Over to you, Rajeshri.
Thank you, Nitya. Thank you, Nitya, for the kind introduction. I'll now share my screen. And I'm really privileged to have a star-studded panelist, so that I just have to put in the questions and we will all have the answers readily. Has it come to slideshow?
No, ma'am. Please click on from beginning.
No, I'm not able to view one half of it. Yeah, I have clicked. Yeah. Okay.
Yes, ma'am.
Yeah. So today we are, normally we have seen about complications in the postpartum period like PPH, anemia, diabetes, preeclampsia and eclampsia. These are topics that are well covered and we are watchful for, and we look out for these complications. So today we have taken 3 topics which have been rare, but which are increasing in frequency relatively. You have peripartum cardiomyopathy and venous thromboembolism. We are going to discuss these 2, and we are also going to address immunization postpartum. I welcome all my panelists, Dr. Dhanlakshmi, Dr. Justin Pal, Dr. Shanti Gun Singh, Dr. Vijayalakshmi Balakrishnan, and we will go on to the first case discussion, which is Sahiti. I'm not able to see this end of it. Yeah. Mrs. AK, 30 years old, para 2, life 2, had spontaneous vaginal delivery 3 weeks back. Her pre-pregnancy BMI was 28 kilos, 28 kg per meter squared. She developed gestational hypertension at 36 weeks gestation, and she was placed on tablet labetalol 100 milligram BD. Her complete blood count, liver function test and renal function test were normal. Following delivery, her BP settled down and tablet labetalol was gradually tapered and stopped 2 weeks after delivery. She now presented 3 weeks after delivery to the ER with breathlessness, orthopnea, palpitation, and fatigue since yesterday, last evening. On examination, there was no pallor. The JVP was not elevated. There was bilateral pitting pedal edema. Her pulse was 110 per minute. Blood pressure 120/70, temperature was normal, respiratory rate was 26 per minute, and SpO2 in the right arm was 92%. On auscultation, she had S3 was heard and a gallop rhythm. The lungs were clear. Per abdomen, the uterus was involuting, and local examination, lochia was healthy. What is the probable diagnosis? Dhanlakshmi madam, could you please take on?
Yeah. Yes, the probable diagnosis, she was an hypertensive, right? But she has resolved. Now the BP is normal. So I wouldn't take that as a postpartum probable preeclampsia going for eclampsia. My first diagnosis would be a peripartum cardiomyopathy. But nevertheless, I shouldn't forget about the other causes for making a similar symptoms in the patient, like dilated cardiomyopathy or myocarditis or pulmonary embolism. But of course, pulmonary embolism will be very dramatic, and hypertensive disorders, because this patient had a hypertensive disorder in the antenatal period, even that shouldn't be forgotten. So, since today's discussion is going to be on peripartum cardiomyopathy, I know this symptoms will be zeroing on it, but when an actual patient comes, I'll be thinking of at least 2-3 possibilities in this differential diagnosis.
So we need to evaluate her. So before evaluating, as you have said, today's discussion is going to be on peripartum cardiomyopathy, and it is a diagnosis of exclusion. So we'll have to rule out all other causes, as Dhanlakshmi madam has said, before we going to conclude that it is PPCM. So it is defined as cardiac failure in a previously healthy woman in the last month of pregnancy or within 5 months of delivery, absence of a determinable etiology for the cardiac failure, and absence of demonstrable cardiac disease prior to the last month of pregnancy, and echocardiographic evidence of diminished left ventricular systolic function. So these 4 criteria have to be met before we conclude that it is PPCM and it's a diagnosis of exclusion. Now, so how are we going to evaluate her? Shanti madam?
No, this patient, as you rightly said, it is a diagnosis of exclusion. Although she had preeclampsia, but otherwise she's a known, not a known case of cardiac disease, either valvular or any dilated cardiomyopathy. We should also ask about the family history. And this patient has developed after delivery. So this is more likely to be peripartum cardiomyopathy, which usually occurs in an asymptomatic woman in the last month of pregnancy or within 5 months following delivery. When we have valvular heart disease, generally there will be, patient would have known that, or sometimes even if she had known, she had not known that she had a cardiac disease, she will have symptoms and signs of cardiac disease earlier, or at least because of the physiological changes, it will manifest at least in the second trimester. So that will include all cardiomyopathy dilated cardiomyopathy, familial ones, all those things. Hypertensive disorders, of course, we can have left ventricular failure, but then after that, she has been adequately controlled and she has been withdrawn even of the antihypertensive medication. We have that Takotsubo syndrome where following any acute stress like accident or even emotional, the left ventricular mechanics get altered, but that will be an acute event, not like this. And myocarditis, of course, we always ask, especially now with the earlier when we had COVID, we had a lot of cases having myocarditis after that. So history of viral fever is very important. Pulmonary embolism, of course, is usually dramatic, but it can be even small embolus, need not be very dramatic. But then generally we will have chest pain, then breathlessness, and breathlessness is usually very marked. And of course, we should never forget myocardial infarction in such in any woman for that matter. But that will usually manifest with chest pain and all these things. So it's very, very important that we think about all these things. And usually that occurs in pregnancy or soon after. So probably we can come to a conclusion. So this patient probably peripartum cardiomyopathy, but always we seek the help of intensivist and cardiologist. So although we generally go along with the history, physical examination, all those things, but then we immediately take the help of our intensivist and cardiologist who give us a clear diagnosis and help us to manage them.
Yeah, we have just put on the full-blown heart failure. What are the physical signs that we can notice? Then,
Yeah,
yes, ma'am.
so we have to see everything.
Yeah. So we just move on to the, as you said, an ECG was taken. Sir, can you please elaborate on the ECG changes in PPCM? This was the ECG, sir.
ECG changes may not be very specific for peripartum cardiomyopathy. The commonest ECG change in any sick patient will be sinus tachycardia. So when a peripartum cardiomyopathy patient comes to us with sinus tachycardia, ECG obviously will show sinus tachycardia. You saw there is, I think, in the upper strip, there is a red arrow, horizontal arrow, both-headed arrow. That is actually the length of RR interval. So when they're more close together, when you see more QRS complexes in one space, that means there is a sinus tachycardia. And as listed, as you can see in that article from European Heart Journal, I think this is Karen Sleva's article. You see a QAVST, everything you can have all these things, but none of them are very specific. So ECG is not really going to help us to diagnose if it is a peripartum cardiomyopathy or not a peripartum cardiomyopathy, but they will be having a lot of abnormalities. But the sinus tachycardia is an important feature of any sickness, including a sick PPCM.
So next we had taken a chest X-ray, sir. How is this going to help us?
The chest X-ray, you can go back and show the chest X-ray. I think it's moved away. Chest X-ray. Now, many times we are not, we don't really see a chest X-ray in an antenatal patient. But however, the amount of radiation that comes out of a chest X-ray is much, much less. So obviously, if there is a need for a chest X-ray, it can be taken if it is going to be helpful. You can see there is a cardiomegaly. You can see the left heart border and the right heart border. And if you look at the left side to right side of the heart, they occupy almost 50 to 60% of the entire transthoracic diameters. There is a cardiomegaly. And you can see that the lung markings, you have a lot of white markings there. So there is, features of pulmonary venous hypertension and pulmonary congestion, as sort of a pulmonary edema-like picture. So this again suggests that the patient has a large heart which is not functioning well. That is the information that this X-ray gives. This could be peripartum cardiomyopathy, or it could be a valvular heart disease producing LV dysfunction, or any other dilated cardiomyopathy. You can't really identify or diagnose peripartum cardiomyopathy based on chest X-ray. It is overall picture, history, examination, and investigation that help us to come to a diagnosis.
So this was, yes, sir, echocardiogram.
Yeah, fine. The echocardiogram, you see that the LV systolic ejection fraction is less than 45%. And echocardiography is a chief diagnostic modality to identify the presence of a dilated heart or the presence of LV systolic dysfunction. Again, it does not diagnose peripartum cardiomyopathy. It tells us there is a LV systolic dysfunction. And it rules out other causes of heart failure or other causes of pulmonary venous congestion. If you look at the chart, I think that the doctor presented, Dr. Ashri presented in the beginning in the differential diagnosis list, where Professor Shanti Gunasingh explained to that. We saw a lot of conditions like hypertension or valvular heart diseases. All that can be excluded by doing this echo. We are removing pulmonary embolism as a differential diagnosis. You can see that the right side of the heart is small and normal in size. It is not a pulmonary embolism. You can see the valves are normal, so it is not a valvular heart disease that produces this kind of picture. It only tells us that there is LV systolic function is less, ejection fraction is less, and there could be some mitral regurgitation, and many times there are right ventricular systolic dysfunction also. So with this picture, this could go with this echo alone can take us to a peripartum cardiomyopathy or a pre-existing dilated cardiomyopathy. But history has clearly ruled out that it cannot be a pre-existing dilated cardiomyopathy because she was asymptomatic during the antenatal period. It started only subsequently. And that has been very nicely explained by one of the panelists, that pre-existing dilated cardiomyopathy, they usually become symptomatic in the second trimester, the 24th week or 28th week, and the blood volume is quite increasing.
What is the role of brain natriuretic peptides, sir?
Natriuretic peptides are now taking a very big role in the clinical practice. And whenever we find a BNP of more than 100 or NT-proBNP of more than 300, we always suspect a heart failure. But what happens in pregnancy is that there have been a couple of studies on BNP in pregnancy, and very recently we have started having data on NT-proBNP in normal pregnancy in the absence of heart failure. So what has been found that there has been a serial increase in BNP levels as the pregnancy proceeds. But however, only 5% of the normal pregnant women have an NT-BNP value more than 100. So by and large, when the normal, usually regular cutoffs are exceeded, you can always suspect a heart failure. And similarly, the usual cutoffs for NT-proBNP still can be used. There was a recent update in 2021, I think, in the European Journal of Endocrinology, where they had done a large study on NT-proBNP in pregnancy, normal pregnancy without heart failure. And what they had found was significant, very large, 99 percentile were normal. So these two cutoffs can be safely considered for diagnosing heart failure in pregnancy.
What about any role for troponin, sir?
Yeah, troponin is a sign of myocardial injury, unlike the NT-proBNP. Whenever the NT-proBNP is elevated, what we really find is it is the pressures inside the heart are high. The atrial pressures are high, the ventricular end diastolic pressures are high. So as a result, you have the natriuretic peptides coming in. Now the troponin comes in what we find is it is due to a myocardial injury. It can be whenever in a heart failure, the troponin is also elevated, it points out to a high risk condition. You don't have to have a troponin to diagnose heart failure. NT-proBNP is sufficient, but the addition of troponin elevation tells us that in a heart failure patient, it could be a more severe form of injury. Now, in the absence of that, whenever we have a troponin, we always, it's a marker of myocardial injury. Any acute myocardial infarction or acute coronary syndrome or any STEMI or NSTEMI, there will be elevation of troponins. And in pulmonary embolism, again, there could be elevation of troponins. So in heart failure, presence of troponin elevation marks a higher risk. So there is a panel like, how frequently should we check the BNP? You don't really have to routinely check the BNP in all the pregnant women. If you have a suspicion that the patients, normally there was a very large study of 25,000 women with dyspnea in pregnancy. In that, what they had found was in 50% of them, evaluated the symptomatology of dyspnea in pregnancy, half of them did not have dyspnea, 50% did not have dyspnea. And the remaining 50% had dyspnea, of which 45% were evaluated and found to have no cause for dyspnea, no significant cause for dyspnea. The remaining 5%, of the remaining 5%, 92% had anemia as a cause of dyspnea. So, when you have a dyspnea, which is disproportionate to the usual, pattern that we see when we rule out anemia and all that, you look at a BNP levels, the BNP levels are high, then you suspect the presence of a possibility of a heart failure.
So as has been, any other investigations that needs to be done? MRI?
Well, cardiac MRI is not going to be helpful during pregnancy. Now, in a peripatient with peripartum cardiomyopathy, by and large, cardiac MRI helps us to diagnose the presence of fibrosis in the myocardium. Now, in a patient with peripartum cardiomyopathy, when she's settling down, if you do immediately MRI, the late gadolinium enhancements may not be there at all. There may not be any markers of fibrosis. There is a potential for recovery. But many times, as the time progresses, those who don't recover, they many times develop a fibrosis in the LG, late gadolinium enhancement may be more prominently seen. So it is not routinely necessary to, I think a cardiac MRI straight away we can say antenatally is not at all necessary. And postnatally in selected cases when they don't recover, when we would like to prognosticate, we can definitely do a cardiac MRI. I probably would have done cardiac MRI in about 15 to 20 patients so far, that is all, in peripartum cardiomyopathy. And cardiac biopsy definitely is not at all indicated. And particularly when a patient is, going beyond 6 months to 1 year and recovery is not there, when you suspect the presence of other infiltrative cardiomyopathies like sarcoidosis or amyloidosis or any tuberculous infiltration or giant cell myocarditis, we probably can consider a biopsy. That is not something, you will look for.
To summarize the algorithm, so first the history, we come to a conclusion, differential diagnosis, and the cutoff has been mentioned. Its negative predictive value is higher as far as BNP and pro-BNP are concerned to rule out the heart failure. Then when you suspect acute PPCM, then we go ahead with ECG, X-ray, echocardiogram, where natriuretic peptides are available. Yes, it can be done. And when it is elevated and left ventricular ejection fraction is less than 45%, likely PPCM. You have to consider, like Sir said, other cardiomyopathies and which can be ruled out by the history and time of onset. If the peptides are elevated and the ejection fraction is more than 45%, then we'll have to consider other causes like pulmonary embolism, amniotic fluid embolism, isolated right ventricular dysfunction, hypertensive disorders of pregnancy, eclampsia and sepsis. And if LV natriuretic peptides are normal and ejection fraction is more than 45%, then we'll have to see the extra cardiac origin of symptoms like Sir has said, anemia, hypertensive disorders, eclampsia, and depression. So the next is how do we manage? Ma'am, Shanti ma'am, Can you tell us how do we manage this patient? Yes,
Yeah.
we will involve the cardiologist, but first we will have it from you, ma'am.
Yeah. The thing is, generally, and one thing what I wanted to place on record is, earlier when we were all junior assistants, we never used to see so many cases of peripartum cardiomyopathy. But now, maybe because of awareness of what we do, I really do not know, we are seeing more cases of peripartum cardiomyopathy, and with the good interdepartmental management, they really, we have good outcome too. But then we should also understand that certain patients are really very sick and they need to be admitted, not in an obstetric unit. They should be shifted to a place where good cardiac care with advanced procedures are also there. So beta blockers, they are the sheet anchor. And of course, as we know, we don't use ACE, ARB in all these patients. That is both in pregnancy and later. And I will call a cardiologist and I will hand over my patient to him and listen to what he is doing and follow the instructions very implicitly. That is what I would do. So I think you should ask only.
Sir, we request you to take over, sir.
Madam, thank you. But though Madam is speaking very humbly, as if she doesn't manage at all. Let me tell you that it is the logicians who manage everything, and we just fill in the blanks now and then. With all they're doing a wonderful job. Whenever we do a good cardio obstetric work, we are happy about it. But I've shared a couple of publications that we have done in this area, pregnant women with the heart disease, and 3 articles I've shared. And I also found one question from Dr. Kundavi on risk of subsequent pregnancy if they can pregnant again. I'll discuss that later, but I've shared one of our abstract we published, President of the European Society
I have a
of
question on that also, sir.
Yeah. For that, I have shared that our data
Okay,
in the subsequent pregnancy. Now, in the antenatal period, see, predominantly the most important thing is the hydration part of it we need to maintain. We should not overload the patient. We need to really dehydrate these patients. At the same time, you need to watch for unnecessary, avoid undue dehydration as well. So keep the patient dry. How do we keep them dry? The SOS loop diuretics as necessary. And if you look at the pillar, we nowadays have something called 4 pillars of heart failure management. There is, sacubitril valsartan. That is ARNI we call. Angiotensin receptor neprilysin inhibitor is an important pillar. But however, there is no data on these in the antenatal women, so we cannot give that. The other one is SGLT2 inhibitors, dapagliflozin, empagliflozin. Again, in the antenatal period, we don't have any data on these, so we cannot give that. The next pillar we have is, MRAs. That is what we have is eplerenone and spironolactone. But again, we cannot give this in the antenatal period. The only thing that we can give in the antenatal period as far as the 4 pillars are concerned are the beta blockers. So I think that is why Madam rightly pointed out we need to give beta blockers, but then beta blockers have to be very cautiously given, very slow dose and uptitrated, and loop diuretics. And hydrolysin and isosorbitdinated combination can be given, and digoxin can be given. It is very important that I think ACE inhibitors, ARNI, and SGLT2 inhibitors or MRAs are not given. And in a patient with a very severe cardiogenic shock, when the EF is less than 20-25%, the cardiogenic shock is there. All possible supports that we usually give for the support, like mechanical cardiac support, we have the Impella catheters, we have indwelling ECMO, biventricular. All these can be done for this peripartum cardiomyopathy patients, and there is enough and more data now that there are a lot of publications on the use of mechanical cardiovascular support for these kind of patients, but by and large, many of them may not really need. Now, what about the delivery? I think it is very important. You are rightly pointed the importance of the cardio obstetrics team. In India, I feel that, if I were the health minister, I will order that every institution having a cardiologist and a physician should have a cardio obstetrics team. and everything should be done with a team approach. That is extremely important because of the ongoing obstetric transitions. We are going to have an increased proportion of women dying due to heart disease in pregnancy. Like the cardiac diseases is going to be the largest contributor of maternal mortality in India in the years to come. In 2011, it was 4.4% in Tamil Nadu. In 2021, it is 11% in Tamil Nadu. In US, it's about 30 to 35%. So India, as we are improving, as physicians are taking wonderful care of managing infectious diseases and hemorrhagic causes of maternal mortality, the cardiac complication is going to increase in terms of relative proportion. So we need to really involve the cardiobstetric team, and when do you need to monitor and all that, fluid overload. And after delivery, again, we need to be extremely careful because most of the deaths happen in the first 1 week of delivery. We really need to be extremely careful in terms of watching for fluid overload and that. And after delivery, we are more comfortable to give beta blockers. In addition to that, enalapril, spironolactone, and even ARNI we can give. And again, we use these drugs, bromocriptine and cabergoline, in peripartum cardiomyopathy. They are not to be used in the antenatal period. They again can be used only in the postnatal period. And in the echocardiography, I think one of the points that we need to look for is the presence of thrombus. LV thrombus or intracardiac thrombus is very common in peripartum cardiomyopathy, being a thrombogenic milieu of pregnancy. On top of it, severe LV dysfunction and reduction in stasis, increased stasis, there is a thrombus formation. If there is a thrombus formation, we really need to give a therapeutic anticoagulation therapy with these patients. After delivery, we can definitely give peripartum cardiomyopathy. For peripartum cardiomyopathy, you can give bromocriptine. But then bromocriptine is definitely, we don't have a very large data to make it as a blanket recommendation for peripartum cardiomyopathy. There has been small scale data here and there starting from South Africa, Karen Sliwa Group and Hanover Medical School, Hilfiger Cleaner. These two are the people who really started using bromocriptine. There was a proof of concept study done by Hilfiger Cleaner in Hanover Medical School on rats. In pregnant rats, they used induced peripartum cardiomyopathy and they gave bromocriptine. They found that the rats' LV function improved. And as a result, in 20 patients, Dr. Karen Sliwa in South Africa, along with Cleaner, they started a study. 10 patients with bromocriptine and 10 patients with the bromocriptine. The dose that used was 2.5 milligram twice a day for 2 weeks and subsequently once a day. What they found was their small study showed very significant improvement in LV function, good outcome in the bromocriptine group, but it was too small to be of any statistical significance. Then subsequently, there are a couple of studies, but then all these studies are having their own limitation. So in our practice, what we really consider is in a patient who has a severe LV dysfunction, severe heart failure, EF 30% or less, in a postnatal period, we start bromocriptine. Again, 2.5 BD for 2 weeks and then 2.5 OD 1 week. The thing is, bromocriptine also adds to the thrombogenic milieu. So whenever we start bromocriptine, we always start prophylactic anticoagulant therapy also in these patients. There have been a couple of studies on cabergoline also whenever bromocriptine is not available, but the data is not too strong. So we will not routinely recommend bromocriptine, but then in very severe patients, when you don't have anything else to do, you can definitely try bromocriptine. We have had mixed experiences with bromocriptine. I still have a couple of patients, young women, coming to me with having instituted bromocriptine the right time, but still they are having the LV systolic dysfunction non-improved. This is one of the problems that we always face. But timely management, timely recognition, and the appropriate treatment, it is likely to save a lot of women who otherwise may lose the light of the world. And it is lactation, again, there are some questions like, whether suppressing this lactation, is it going to be helpful or not? But I think, there are now data that, this has not been of a great issue. So do not worry, you just, because you can continue bromocriptine when there is a cardiac need to give bromocriptine.
So this is the follow-up echo after 3 months, and the patient has showed improvement in ejection fraction.
I think this is a good thing for this patient. I think this is what we normally see. Thankfully, many patients recover. Now, the recovery rates in peripartum cardiomyopathy are, how long do we wait? Is ejection fraction more than 55 or 50? Initially, they thought it may consider 50. Now, I think most of the people are looking at EF more than 55 as a better predictor of complete recovery. And when do we call it really recovered? Whether this, what do you call that, 55% is sufficient, or what I personally believe is we need to do further echocardiographic parameters like GLS, where the GLS has to be normal, and then stress echocardiography. In the stress echocardiography also, the LV function has to be normal. Then we can consider over a period of time, step by step, one drug withdrawal in 6 months to 1 year time, and watch the LV function, then watch. This is a strategy that we can consider. Any patient who's wanting to have a subsequent pregnancy, to answer Dr. Kundavi's question, what we really look at is in patients with persistent LV dysfunction after peripartum cardiomyopathy, they do very badly after subsequent pregnancy. So we need to advocate these women not to have become pregnant again if they do not have an improvement in LV ejection fraction. And in these patients with improved ejection fraction, get all these things like including stress echocardiography, GLS, if all the parameters are good, there is a reasonable chance that they can go through pregnancy subsequently well. Now, in the data that I think I shared, and which is present ESC, about 8 patients in our series went through subsequent pregnancy. All the patients who had a normal LV function recovery, they did well in the subsequent pregnancy. So we are comfortable in allowing a patient with the recovered ejection fraction to go through pregnancy. What percentage of them recover? I think you have given the percentages also. Like 50% of them recovered with improve with standard medical treatment. How long we can wait? But I think the 50% is better in most of the data. Some of the data now, there is a study from McNamara in the US, IPAC study group, pregnancy and cardiac disease study group, where the recovery rate at 12 months was 72%. So, and in another study, there was some thought that, this breastfeeding may delay recovery. That is one of the issues that, even if you don't give bromocriptine, should we allow the mother to do a breastfeeding? So there was one study where for half of the patients, they did not allow breastfeeding, another half, they allowed breastfeeding. And what they found was breastfeeding did not hamper recovery. So we encourage, women with moderate and mild forms of peripartum cardiomyopathy to go ahead with the breastfeeding, except in very severe peripartum cardiomyopathy where we don't have enough data to say that. And most of them, as I said, 50% recovery at 6 months, another 20% recovery at 12 months. But recovery up to 12 months, also in 24 months to 36 months also have taken place. And looking at the complication part of it, I think, as the arrhythmia are more common, there are some cases where implantable cardioverter defibrillators have been fixed in women with peripartum cardiomyopathy. Very few of them have undergone EF studies and RF ablations. Otherwise, these are the complications that, you have rightly pointed out in peripartum cardiomyopathy.
So they're now talking about the genetic testing after we have stabilized the patient. The choice would be targeted sequencing for the known cardiomyopathy genes or for all genes through gene exome. By doing that, if a mutation can be identified, genetic counseling can be done and cascade screening of relators, and we can identify those at risk and tailor cardiac follow-up. This is being suggested after the acute condition has improved and the woman has settled down. And regarding contraception, Dana madam, what contraception can be provided? She is
para 2, live 2.
Live 2, yes.
So the first option would be to go in for a permanent sterilization. Yes. And if the patient had been a primary gravida, probably I would think of a progesterone-based temporary contraception like implants, or what is available is DMPA, and DMPA is readily available. So I would prefer a DMPA injections, quite comfortable for the patient as well. So I wouldn't be using any estrogen containing combined contraceptive pills.
So summing up, the EQ pathology is you have a genetic predisposition or a familial indication or a cardiomyopathy ethnic, along with multiparity, with the other risk factors, twin pregnancy and smoking in a healthy woman. when pregnancy is added on, where you have the angiogenic imbalance, endothelial dysfunction, physiological stress, inflammation, and preeclampsia, leads to peripartum cardiomyopathy. This would be the etiopathology, and the incidence is 1 in 837 to 1 in 1,374 deliveries in South Asia. And to sum up it all, with increasing awareness and better diagnosis, PPCM has moved from a rare to a relatively frequent pregnancy complication. And therefore, we should be aware of this, and it should be suspected. We have already told you about the diagnostic criteria, that it should happen towards the last month or the first 5 months following delivery, and confirmed left ventricular dysfunction, and after ruling out other causes. Genetic predisposition, physiological changes, and other risk factors accumulate to induce PPCM in otherwise healthy women. After history taking, all women should be thoroughly assessed. Physical examination and alternate causes should be excluded. Urgent cardiac investigations will be ECG, BNP measurement, if available, should be performed. And then echocardiography follows as the next step in investigation. Patient with abnormal cardiac investigation should be referred to the cardiology team urgently. Genetic workup should be considered if there is a family history of cardiomyopathy or sudden death. Maternal mortality rates range widely from 0 to 30% depending on the ethnic background and the geographic region. And just under half of women experience complete myocardial recovery. The women should be educated to avoid future pregnancies, as Sir already said, if ejection fraction fails to improve, as it increases the mortality up to 50%. We will now move on to case 2. And here is Mrs. AP, 23 years old, primi gravida. She had a spontaneous vaginal delivery last evening. Both she and her baby are doing well. Her antenatal period during this pregnancy was uneventful. But prior to the pregnancy, she had gone for a pre-pregnancy counseling only 3 months after marriage, as her husband was traveling to Africa the next month. She was advised rubella IgG by her gynecologist pre-pregnancy, and she tested negative, IgG negative. In the meanwhile, she is tested positive for pregnancy, and she's gone through pregnancy and she is delivered just now. She wants to know if she can have her MMR vaccination now following delivery. Dr. Vijayalakshmi, can you please take over?
Hello, everybody. Basically, vaccination in the postpartum period is pretty safe. And one problem with our country is people do not get vaccinated that frequently, especially adults are not comfortable with vaccination. And this is one period where we have access to them. So if somebody has not had a vaccination, this would be the right period to do it. So rubella vaccination, either as MMR or rubella alone, in this period is pretty safe for the baby and for the mother.
So her postnatal period was uneventful. She was about to be discharged on day 3, but her niece at home developed chickenpox. She has nowhere else to go. She has to go back to her own house. What do we offer her now, as she would be staying with her niece? She has not had chickenpox so far, is what she says. Should we offer her immunoglobulin? Should we vaccinate her? What about the baby? Shanti ma'am, I'll first hear from you, then we will move to Vijayalakshmi ma'am.
Okay. So this lady, what I've been her, she gives no history of chickenpox.
Yes.
Chickenpox earlier. But
Yes.
then I've seen so many times that people who have not had chickenpox even have IgG positive. So this patient, I will always do an IgG. And if it is positive, she is immune. If she is negative, still I will go ahead with vaccination. And I don't think I will permit her to go home. There are so many options in Chennai now. She can go to somebody else's house. There are a lot of hotels probably for some time. So IgG I will do. History is negative. IgG I will do. I will vaccinate her now. That is what I will do. And I would also probably, and I will see to that she doesn't go home now.
Dr. Vijayalakshmi.
Dr. Shanti kind of summarized it very well. Basically, first thing is going to be ensuring that they don't meet. Because this chickenpox is airborne, it spreads very fast. If you're in the same room for half an hour with another patient, chickenpox patient, the chance of you getting is more than 90%. So invariably, if they are in the same house exposed, the mother gets exposed. And from the mother, baby will invariably get exposed by the time the baby will be less than 1 month when the window period ends, and that will be very dangerous for the baby. So first is physically separating them will be the first option. Vaccinating the mother. Those two things should do. Meanwhile, if you could get the IgG to be positive, we can just ignore and send her back home.
Thank you. So we did that. 2 months after delivery, she comes in depressed as her mother, 45 years, was diagnosed to have cancer cervix. She's worried and wants to know about HPV vaccination. What do we advise? Role of HPV vaccination in postnatal period. Dana ma'am, we could first hear from you.
Yes, yes. This is one of the vaccines that is being promoted largely as a postpartum vaccine. So even though she has crossed her age limit is 9 to 15, they have a very good immune response to HPV, but the extended time is till 26 years. But you have to insist on with this patient that even though she can get vaccinated with almost 50 to 70% efficacy, she should be in a regular screening program as well. This is the time you can talk to her, and if she had not had any pap smear screening so far, you can put her into the groove, and vaccination can be done, provided she understands it's not as efficacious as when given between 9 to 15 years. So you can choose a vaccine that is available, one either quadrivalent or quadrivalent is what I would prefer. The bivalent so far is not, we don't recommend these days. We are advising only quadrivalent vaccine. They can safely be given. It goes with the baby's immunization schedule as well, 0, 1, and 6. So it's nicely taken up by the postpartum mothers.
Dr. Vijayalakshmi.
Can I make a point, Rajshri?
Yes. Yes.
When we were giving that MMR, that time itself, I think we should take it as an opportunity, talk to go about HPV and then give it in the next deltoid. That is what I think. Because she was very receptive about immunization. That itself is a big thing. So one side MMR and one side HPV vaccine would have been ideal.
Dr. Vijayalakshmi, can we have your views?
Basically, this vaccine, we had several large trials. One was a Swedish trial where they followed, it was more than 100,000 people followed up. And what we found out was when your age is less than 17, the protection is almost like 85 to 90%. As you age till 30, there is some immune response after that, nothing much. They were followed up for nearly 11, 12 years. In our country, I'm talking about India, the cervical cancer sets in a decade earlier. That's probably in 30s. We start screening with 30, 35 because we know that by the time they're 40, we do have a sizable chunk presenting with that. So ideally, we should probably vaccinate all the female, probably around 13 to 15 years. We can't get them in your school. 10 standard certificates will probably be the best time to vaccinate them. Coming to women like her, who's asking for it, yes, fine. But can we make it a community measure? Is it good enough? Does it produce a good response? Is it cost effective? Probably the answer is no. Once they cross 17, 18 years, the cost effectiveness in a country like India may be less. But for an individual patient, especially when they can afford it, it definitely may be helpful and we can offer it. But along with this, I would offer influenza vaccination if the patient has not been vaccinated. That really helps. Another vaccine which we can consider is your typhoid vaccine. Your enteric fever vaccine is quite efficient. It's available now. And most of the time, we don't get to vaccinate the adults. And if there's a chance like this, that will really help.
Okay, thank you. And finally, she'll be traveling to Africa with a baby now. Her husband is already there. So she wants to know about malaria prophylaxis. She's breastfeeding and is concerned for her baby. What do we offer her?
So if they're traveling from one endemic area to another endemic area, we generally don't offer prophylaxis. So for the women, we don't require prophylaxis. Coming to the baby next. Do we really need to give prophylaxis to the mother to help the baby or something for the baby? A child less than 1 year, none of the prophylactic regimens we have are extremely good. And then if you're talking about Africa, it's going to be falciparum. We really cannot give chloroquine. You have to go for mefloquine or atavaquone, lemifantrin. All these things are very difficult for the baby. At this point of time, I would say protect the baby or delay it for some more time till the baby crosses 1 year. and no prophylaxis is needed for the mother.
Thank you. Anything else that you, so this will be the take home: postpartum and breastfeeding, COVID-19, influenza, Tdap, hepatitis B, hepatitis A. Now Dr. Vijay Lakshmi has added typhoid, meningococcal and pneumococcal were required, HPV, influenza, both live attenuated and inactivated, MMR, varicella. These are the vaccines that can be given in the postnatal period. We will move on to the next case scenario. A 35-year-old primi gravida just delivered a 3.6 kilo baby at 39 weeks of gestation by emergency cesarean section for fetal distress. She has no prior history of family history of VTE. BMI is 32.7 based on pre-pregnancy weight 89 kilo and height 165 centimeter. No other medical condition. Both mother and newborn are doing well now. A few hours after delivery, the mother asked about the need for prevention of venous thromboembolism. Shanti madam, why are we concerned about thromboembolism? Are we in puerperium? Ma'am?
Yes. So now we know pregnancy itself is a risk factor for it is a hypercoagulable state and a risk factor for thromboembolism, and postpartum is still more. And that really continues up to 6 to 12 weeks. So first 6 weeks, we have to be really very, very careful. And we are seeing some deaths with thromboembolism. So I think it is really very, very important. And we have, we have certain conditions to identify it, risk stratification to note who are the, women who are at higher risk and offer treatment too. So I think this is very, very important.
Sana madam, why is the risk of VTE more in puerperium?
Yeah, the Virchow triad nicely fits into this postpartum period. You have a very highly coagulable blood because of the increased procoagulation factors, and this is stasis. And not only the pregnant uterus, even a postpartum uterus is heavier than a non-pregnant uterus. So that itself can have a compressing effect. And there's a hormonally mediated vein dilation. It takes about 6 weeks for it to disappear from the system. And the patient is relatively immobilized, especially after cesarean, like your patient had. She could be immobilized at least for a minimum of 24 to 36 hours. And vascular damage happens by default when you're doing a cesarean section, and especially when it is an operated deli like your patient had. So all these are perfectly fitting or setting the stage for a virtuous triad to happen. And so VT is expected almost 100% in this patient.
Yeah. So it is a single cause of death most amenable to reduction by systematic change in practice. Therefore, it's very important to be considered seriously. And what change in practice do we need to do? As Dr. Shanti madam has already said, we have to risk stratify them to find out which women are at risk, whether they are low risk or high risk. We have to stratify the risk and give them thromboprophylaxis as needed according to the risk. So when do we stratify the risk? Dana madam, when should we perform the risk assessment?
It should be performed right from beginning, by pre-pregnancy, especially your patient who's little on the heavier side, and early pregnancy. From that time onwards, you should start stratifying them, whether she's high risk or low risk, or anytime she is hospitalized, where, for example, she's got a high GTT values and she was admitted, or a high BP value, she's admitted. Anytime she's hospitalized, take that opportunity to stratify her once again. During the intrapartum period, if she immobilization longer period of time, because she would have gone for an induction. So we do not know what type of induction method was used, because she was taken up for an emergency section. Immediate postpartum is a period high likely to precipitate a VTE, and at the time of discharge. So all these times we should be on a continuous. She is a high risk for developing VTE, not only this patient, any pregnant mother as such.
So this patient, as we can see, when you look at the risk factors, she had a cesarean section in labor, and therefore she falls under intermediate risk, which means she should have at least 10 days of postnatal prophylactic low molecular weight heparin. Plus she's around 35 years, obesity, and these two risk factors again place her under intermediate risk, and she was advised 10 days of postnatal prophylactic low molecular weight heparin. And so how are we going to manage her now?
So it is very, very important that we have to mobile early ambulation and good mobilization. Now all of us insist on that, and adequate hydration too. That we should keep on insisting. We should tell the woman as well as her attenders to permit her to drink plenty of water and walk about. And of course, when they are, we will put them on prophylactic heparin, and this graduated compression stockings also help. And this is post-surgery. But if it is during surgery, prolonged surgery and all that, we use that intermittent pneumatic compression. And we have to keep on observing them whether they are developing any problems. So that is also very, very important.
If the patient is not affordable for the stockings, we teach the relatives how to squeeze this calf muscles to kind of do the same job.
Yes, so Madam has already told about the intermittent pneumatic compression. So this is what we say, but if we look at women's view and adherence to the postnatal prophylaxis, many women qualify for thromboprophylaxis following childbirth. However, little information exists on how adherent women are and their experiences to both pharmacological and mechanical forms of thromboprophylaxis. Adherence to low molecular weight therapy was relatively high, 82.4%, whereas suboptimal adherence level to the stockings, anti-embolism stocking, with 24% stating that they never wore them once at home. Reasons being they are mobile, feeling hot and feeling as if they were cutting circulation off the legs. But for intermittent pneumatic compression, yes, that is during cesarean section, they would be happy to have it, and future delivery also if required. So now the non-pharmacological method is over. Dana Madam, the pharmacological methods?
We generally tend to use a low molecular weight heparin. Fondaparinux, we don't have much experience. And the other thing like warfarin, we consider only if you are going to stop heparin and going to continue anticoagulants for a longer period of time. Otherwise, most of these patients for 10 days, we complete with heparin itself, low molecular weight heparin itself.
So the anticoagulant of choice is low molecular weight heparin because of the longer half-life, higher bioavailability, more reliable anticoagulant effect, subcutaneous injections less painful, lower risk of heparin-induced thrombocytopenia and osteoporosis. Should we perform any investigation before thromboprophylaxis? No, yes, not required. And the dose of thromboprophylaxis?
Yeah, this depends on the weight of the patient. Since the patient is, so you can calculate as per the weight. Our patient is up to 90 kg. So 40 mg of Clexane is what we use. Sometimes we do use a fragment, which is 5,000 units daily. The other anticoagulants.
Should we monitor any?
Not affordable and sometimes low molecular weight.
Unfractionated heparin.
Unfractionated heparin, but then 2 doses should be given.
5,000 international units.
Twice a day.
Yes, yes. So should we monitor any parameters?
No, not necessary.
Not necessary. So this woman was offered 10 days of prophylactic low molecular weight heparin in view of intermediate risk. She refused and asked for discharge. She now comes back after 10 days of delivery with left leg pain, discomfort, swelling, and difficulty in walking. What is the probable diagnosis, Shanti ma'am?
Probably it is deep vein thrombosis. We have to think about that, rule out deep vein thrombosis. So clinical examination and Bowman's sign also should be seen, but it is not absolutely reliable. We have to go in for ultrasonography. That is very, very important. Do play ultrasonography to see for the flow in the vessels and see for any problems. But then if it is pelvic higher up, then probably this alone might not be enough. So that also we should keep in mind. So ultrasonography, D-dimer might not help now much because she's the puerperium, and the values cannot be depended much upon
But
because
if it is normal, then we can at least rule out
Negative
predictive value.
Yeah.
But you can do a Doppler, madam. If you are suspecting deep vein, pelvic DVT, you can go in for a Doppler.
Yeah. So if compression sonography is equivocal, if Doppler testing is abnormal, or the suspicion of DVT is high, then we require further maybe serial compression ultrasonography or MRI in the postpartum period. So what do we do now? We started on low molecular weight heparin because we have diagnosed
therapeutic dose.
Therapeutic dose.
And we need to do certain investigations because we are giving her a therapeutic dose now, a complete hemogram, renal function test and liver function test and coagulation.
If the renal function is not all right, we are not going to give the same dose. We should be really cautious.
Yeah, but performing a thrombophilia screen prior to therapy is not recommended. So what is the therapeutic dose?
It is either enoxaparin, we go by per kg calculation, or dalteparin, and we are not monitoring anti-XA 10-XA level on a routine basis. But if it is done, it should be within the target of 0.6 to 1.1. And you have to measure it after the last dose. Suppose she takes it at 8 o'clock in the morning, maybe 12 o'clock, you can measure and see.
For how long should we continue?
Minimum 6 weeks.
At least 6 weeks postpartum. And are there any contraindication, as you have already said, cannot be given?
Yeah, one is a renal disorder. So
yes.
we'll know when the creatinine is more than 1.1, then we don't give it. Or liver disease, we raise prothrombin time. Or if the patient is already known 1 milligram disease per patient, or platelets is less than, we keep it as a target of 80,000 and 75,000. Or this is very rare, but which had a stroke in the last 4 weeks.
So when will you prefer unfractionated heparin?
As Shanti madam said, if the patient mainly cannot afford, but otherwise the LMWH scores over heparin. If the creatinine clearance is not good, like in a renal patient, or the weight is more than 150 kg, because it is preferred, especially if the patient is about to go in for a surgery. That time we prefer heparin because it's easily reversible.
So what to do if there is severe heparin-induced thrombocytopenia? Shanti ma'am, you want to take it?
No, I see only up to unfractionated heparin and low molecular weight heparin, I will manage. After that, earlier itself, even with the DVT, we would have called in an intensivist as well as, so we would have got your opinion too to help us in management, because there can be embolus elsewhere which can be quite mild, but which can cause problems, a lot of things. So I think we will start off the drug, but then after that, the spondopharynx, all that, I think I will get opinion and then only.
Okay. Is there a role for a oral anticoagulants?
Yes, if it is needed, then we have to go in for a bridging therapy, where we have to give this warfarin very carefully. 1 milligram, 2 milligram, that's what my patient currently is undergoing, this bridging therapy. 1 milligram and the next day 2 milligram till they reach INR of about 2. Then we can stop this heparin and change over to warfarin completely. But that changing over, that bridging therapy is very, that period is very stressing both for the patient and for the treating consultant. But
now
they are safe during breastfeeding.
Yeah. Now all intensivists seem to be very fond of this rivaroxaban. All that has really taken over. But then in puerperium, and that is in breastfeeding, not much data. So probably we might not take those two. I think probably you can get opinion from our cardiologist also.
Yes, I'm going to, because when you, so when do we start suspecting pulmonary embolism, sir? I want you here, sir. Sir, Justin, sir, are you there, sir?
Yeah, I'm there, madam. I'm there. Okay.
Yes, sir.
So, to you, good deliberations. Like, you have been talking about venous thromboembolism and prophylaxis. And there is now more and more data that, this novel oral anticoagulants are not causing any big damage in lactating mothers. So data is increasing for the use of rivaroxaban, apixaban in lactating mothers for venous thromboembolism prophylaxis. They may become more comfortable to the mother and more acceptable because they're just oral tablets compared to the injections that we talk about it. And when do we suspect pulmonary embolism? A patient becomes dyspneic, a breathless patient. Venous thromboembolism will not produce breathlessness. We have to remember that will not produce breathlessness, will not produce tachycardia. So if there is a heart rate more than 120 in a patient suspected VTE, invariably pulmonary embolism is a very high possibility. So we really need to look at the heart rate, tachypnea, breathlessness, and chest pain. These are the pointers towards, in fact, there are situations where we had actually missed diagnosing pulmonary embolism in the right therapy. And when they present, pulmonary embolism can be massive or submassive. We call it now high risk, intermediate risk, and low risk. When there is a BP drop, when there is a hypotension, we call it a massive or a high risk pulmonary embolism. The treatment for a massive or high risk pulmonary embolism is thrombolytic therapy. We should not hesitate to start thrombolytic therapy in a patient diagnosed with pulmonary embolism. Even if there is an OG ward, no need to wait for transfer to the ICU. You can start the lytic therapy there, and then subsequently we can always transfer. Because I'm telling this particularly because we had lost 2 patients in this transfer business where there was a hesitation to start lytic therapy in the non-ICU, or hesitant to start the OBG ICU because obviously we're not used to that, and we are. So obviously you'll feel that it will be safer in the hands of an intensivist or a cardiologist, but at the point the patient needs the therapy most. In our data, we had 6 patients with of this 1,029 pregnancy presented, 6 of them had acute pulmonary embolism, and 2 of them were antenatal and 4 of them were postnatal. Of the antenatal, we thrombolized 1, the patient survived. The other patient, could not even reach, so she died immediately. Of the postnatal, we thrombolized 3 and all the 3 survived. And the 1 patient we didn't thrombolyze is intermediate risk, the patient also survived. So appropriate diagnosis of high-risk pulmonary embolism by looking at this and appropriate management is extremely important. And echocardiography, bedside echocardiography is extremely helpful in diagnosing pulmonary embolism because you'll immediately see that the right atrium is dilated, right ventricle is dilated, and there is a right ventricular dysfunction in massive pulmonary embolism. That straight away, when there is hypotension and there is RARV dilated, the diagnosis is very clear. We, in fact, echocardiography basis, we start thrombolytic therapy for these patients. Otherwise, we can do, and the ECG wise, whenever you find that in the ECG, there is an increase in heart rate. Sinus tachycardia is the most common finding in pulmonary embolism. When there is an increase in heart rate in the ECG, this is going to be very helpful. In the X-ray as well, if you take an X-ray, you may have a Hampton's hum, or you may have signs of pulmonary infarcts. You may have signs of oligemia in the area where the pulmonary artery segment is occluded. And these blood tests all need to be done. And if there is a non-massive pulmonary embolism, heparin has to be started. Low molecular heparin can be started unless contraindicated. And I'm sure you are all very familiar. This is exactly like the therapy for DVT. The only difference will be when there is a hypotension, we always look at thrombolytic therapy. And the intermediate risk patients also, we now divide them into intermediate high and intermediate low based on the presence of right ventricular dysfunction in imaging and myocardial damage by troponins. If there is a troponin elevation and there is a right ventricular dysfunction, the imaging by echocardiography, then we look at classifying them into intermediate high risk pulmonary embolism. Well, CTPA nowadays, the high resolution CTs are now very low radiation to the, the radiologists claim that we have very, very ultra low radiation pulmonary angiograms can be done. So of course, mother's breast tissue can be protected. There is CT pulmonary angio is a very diagnostic possibility for acute pulmonary embolism. Most of the hospitals and CT pulmonary angio is now available. So it can be very easily done.
So you've already spoken about thrombolysis. IVC filter, sir. What about IVC filter?
IVC filter as an entity by itself is now slowly losing its position. Earlier, say about 15 years back, 20 years back, a lot of IVC filters are being deployed, and then now more and more data is coming that it is not very helpful and saying that it itself is acting as a nidus for thrombosis. So only in very niche cases, like a patient who have a recurrent pulmonary embolism despite adequate anticoagulation, they have a very large iliac thrombus or IVC thrombus where it's very high risk to embolize. We can put a temporary IVC filter through the jugular veins, and then we should be able to remove it subsequently. So these are the very niche indications of IVC filter: a very large IVC and iliac thrombus, and a recurrent pulmonary embolism despite adequate anticoagulation. But such patients are going to be very, very remote.
So what about contraception for this lady?
IUCD will be the safe for IUCD and barrier. And again, we should avoid OC pills, combined OC pills.
So what would you advise before next pregnancy? What would be the thromboprophylaxis?
This I would continue for 6 weeks.
Yeah,
And
it should be started
maybe you
and-
can.
Yeah.
And we'll have to evaluate for thrombophilia at the end of 12 weeks. And then if you have a suspicion, you can repeat it after 12 weeks to confirm whether she's suffering from any of the acquired or the congenital thrombophilias. And maybe next pregnancy, I would consider strongly for a thromboprophylaxis.
So to conclude, it's one of the leading non-obstetric cause of maternal mortality, preventable by systemic change in practice. What we should all do is universal risk stratification and start thromboprophylaxis. Risk stratification should be done pre-pregnancy, antepartum, any hospitalization more than 72 hours, intrapartum, immediate puerperium, and at discharge. Heparin, unfractionated and low molecular weight, is preferred for managing VTE in pregnancy and puerperium. DVT and PV, manifestations of VTV, can be consequence of missing thromboprophylaxis. We have to keep on close surveillance and watch. And enoxaparin, the dose has been already discussed. No need for routine monitoring of anti-TNA levels. And also unfractionated heparin. Prophylaxis at 5,000 international units subcutaneous BD, and therapeutic is 10,000 international units subcutaneous BD. So I would like to thank my panelists. I will come out first. Thank you, sir. Thank you, Vijayalakshmi madam. Thank you, Shanti madam and Dana madam. Thank you so much for the excellent interaction that we had and so much of inputs that you have given for us and for all the delegates who have been listening to us. Thank you so much.
Thank you very much for the opportunity, Raj.
Dr. Vijayalakshmi, I have one question. Suppose this patient is going from a non-endemic area of malaria to a malaria infested area. What should be the prophylaxis?
Non-endemic, depending upon, madam. Usually, mefloquine or atovaquone lumefantrine is what we give as a combination. So early in the pregnancy, for example, first 6 weeks to 8 weeks of breastfeeding, you always worry about whatever happens to the baby. So once we cross that period, the babies, now we have enough evidence and it doesn't cause major harm. So the main problem will be the early phase, first 2 weeks, 4 weeks, that's what we're worried about. Afterwards, any one of them should be fine. But atovaquone, I mean, both of them, you can't give it during late pregnancy.
Okay. So this thrombolysis therapy, should it be kept in all the crash cards? Even in OBGYN, we don't have them as a routine in our crash cards. Are they time sensitive with the expiry date?
Sir said after we do an echo and...
I think, madam, what if madam is asking is crash cards, I wouldn't say so because pulmonary embolism, you're looking at the number of deliveries and the number of emergencies you have, and the number of acute pulmonary embolisms you have is be much, much less. But at the same time, it should be accessible from your other stores or other ICU wards or the ULIs, because it's easy to transport a vial than to transport a sick patient.
Yes.
So we can always lyse the patient when we get the thrombolytic therapy when vials from the other ICU wards after the lysing. One point I would just like to add, because particularly when you're talking about pulmonary embolism or venous thromboembolism, when you give a low molecular heparin therapy, we don't need to monitor anti-10A levels. But it is complete opposite when you're using low molecular heparin for prosthetic valve management. In a woman with a prosthetic heart valve, if you're using low molecular heparin, it is mandatory that we need to monitor the anti-10A levels. Otherwise, do not use low molecular heparins if we do not have anti-10A facility at all. I have seen at least 4 deaths in prosthetic valve because low molecular heparin was used without anti-10A monitoring. So I just wanted to share this information.
Only for a short period of time we use LMWH. Mostly we switch over to warfarin.
Yeah, during the short period of time also, safer thing will be unfractionated heparin with APTT monitoring and not LMWH without anti-10A monitoring.
Thank you for this valuable information, sir.
A lot of inputs. Sir has given us a lot of inputs.
Thank you.
Okay. Is going to propose the vote of thanks then.
Yeah, we will. No questions. We'll go ahead. I would really thank OXI President Dr. Jayanani Kamaraj and Secretary Dr. Kundavi Shankar for giving us this opportunity. I would like to thank all the speakers. We will start with Sharmila Yavu for giving that crisp, really comprehensive and up to the point and to date with evidence-based lecture on that breastfeeding. I would like to thank Shilpa for that interesting lecture she gave us on nutrition, postpartum and getting back to shape. And Suresh Kumar sir, he explained to us about what we can handle, the early things, and also what are the questions we need to see if she's gone in for anxiety or depression and when we need to refer to them to take over. And it was really a lot of inputs and we had a lot of take-home messages from you, sir. And then the panel, Sir Justin, sir, really you had your own data, which is from our women, and that is really going to help us. And you've given us a lot of inputs, which we will implement and we will work. And thank you, Vijayalakshmi ma'am, for coming in and giving us all inputs regarding the treatment, and especially we come across on a regular basis. Yes, and we would like to have your inputs also. Shanti madam and Dana madam, I think you did the entire thing. You are the pillar of Shanti madam is one of the pillars of Safe Motherhood Committee, and Dana madam took over. We had and completely put in with animation all the PPT slides that we did today. I'm extremely thankful to both of you. And I would also like to thank Nitya Naram, who is our mock. She took over and did very well in a short period of time. And I would like to thank Shield Pharma for giving us the opportunity, Sahiti in particular for giving us the platform, and a very good one. And last but not the least, the delegates who have been there listening to us till the end. And thank you so much.
Thank you very much.
Thank you.